All right, I'll go ahead and get started, but hope everybody enjoyed their lunch and are ready for the afternoon. We had some really terrific speakers this morning, and so I know this afternoon we'll continue with some other great information to be shared. I just wanted to quickly, because I won't be on later, I guess I should introduce myself again. I'm Megan Scott. I'm the Substance Use Prevention Program Manager at Maine CDC. I just wanted to quickly thank the conference organizers. There's folks on my team and folks on the Child Health team that really did put a lot of time and effort into planning this great day that we're having today. And also, of course, thank you to AdCare, to Lorena and others for all of your work in pivoting to virtual when we had really hoped to be in person again. So thank you so much to everybody who planned this day. Okay, so now it is my pleasure to introduce Dr. Mara Coyle as our afternoon speaker. So Dr. Coyle is a professor of pediatrics at the Warren Alpert Medical School of Brown University and is director of outpatient clinical operations in the Department of Neonatology at Women and Infants Hospital in Providence, Rhode Island. Dr. Coyle graduated summa cum laude from Boston College, where she received her Bachelor of Science degree. She was awarded her medical degree from Brown University as a member of the Dartmouth Brown Program in Medicine. She completed her pediatric residency at the Children's Hospital of Philadelphia and her neonatal fellowship under the mentorship of William O. at Women and Infants Hospital in Providence. She's currently a staff neonatologist at Women and Infants Hospital, chair of the bioethics and perinatal mortality committees, and oversees women and infants affiliated community nurseries. Dr. Coyle's research interest involves understanding the optimal treatment strategy for newborns exposed to maternal opiate medications, and she has lectured nationally on this topic. So welcome, Dr. Coyle.
Thank you very much, Megan, for that introduction. So let me go ahead and share my screen. Can everyone see that okay? Hopefully. Okay, great. So again, thank you very much for inviting me to speak this afternoon about cannabis in pregnancy and lactation. These are my disclosures, none of which have any relevance to this topic, so I'll just move on. So what I hope to talk to you about in the next 40 minutes or so is to provide a brief overview of cannabis use in this country, give a bit of information about legality, both in states and federal, and then to spend most of my time talking about cannabis use in pregnancy and a bit about lactation. And then finally, to provide some information about Academy guidance, which helps to inform the information we provide to our patients when educating them about this topic. And then a couple slides about the information that we provide to our parents at Women and Infants Hospital. So the term marijuana actually has its roots back to the 30s. It's Mexican slang for wild tobacco and was applied to cannabis in the United States as a way of making cannabis sound foreign and sinister. And I refer to the product as cannabis and only talk about marijuana in relation to quoting the literature. And I certainly mean no disrespect if you see the word marijuana used in my slides moving forward. So cannabis is composed of about 500 components, of which a little over 100 are cannabinoids, and the two most studied are tetrahydrocannabinol, or THC, which is the main psychoactive ingredient found, interestingly, primarily in the female plant, and then cannabidiol, or CBD, which is made by extracting material from cannabis and then diluting it in a carrier oil such as coconut or hemp seed. And while CBD products are felt not to be psychotropic, many products do have some minimal degree of THC contained within them. And then in addition to the natural cannabis products, there are the synthetic marijuanas, if you will. Important to understand that the chemical makeup of these is not always known, and more importantly, the effects on the brain may actually be stronger than what we see with the natural cannabis products. So in looking at cannabis on a national level, it remains illegal federally, even though on a state level, there are many states that have approved use both recreationally and for medicinal use. And those are the states outlined in this map in orange. The states that are green are those states that have approved use for medicinal only. And then the gray states are those states that have yet to approve cannabis for use at all. Maryland and Missouri, I might add, are now orange because since this map was published, those two states have approved use recreationally. So when thinking about it on a federal level, it is still considered a Schedule I drug, along with substances such as heroin and cocaine. And by definition, a Schedule I drug is felt to have a high potential for abuse and little to no medical benefit. So you can probably understand why there's a lot of discussion around why cannabis still remains in this class. Oops. So classifying it as a Schedule I drug has significant implications with respect to wanting to study the substance and research, because many drugs in Schedule I that have been studied, really the focus is on causes and consequences of drug use and not, in fact, trying to understand potential therapeutic benefits. And in trying to research drugs that are Schedule I, such as cannabis, historically, in order to receive funding, you needed to use research-grade product, which up until recently was available in only one center in this country, and that was the University of Mississippi. There are other centers where research-grade cannabis can now be procured. There are still regulations and guidelines in order to be accepted to be considered to use research-grade cannabis. So there still are a lot of barriers in wanting to research cannabis to better understand potential benefits, but also possible harms with use. There are some potential changes on the horizon. However, our current president in October of 2022 pardoned thousands with federal cannabis possession charges and asked state governors to follow his lead and pardon those with cannabis-only state offenses. And in August of this past year, the Department of Health and Human Services recommended easing restrictions on cannabis and considering reclassifying cannabis as a Schedule I substance, along with other drugs in that class, such as buprenorphine. So in terms of pregnancy, it is considered the most commonly, and I say illicit on a federal level, substance used in pregnancy, and its use is increasing. In looking at self-reported use in the first trimester of pregnancy, in comparison to the early 2000s, use has increased by over 150% by 2020. And cannabis use is acknowledged to be used most commonly in minority women from underserved regions. In addition, the proportion of the psychotropic aspect of cannabis, or THC, has increased as well. In the early 2000s, products were concentrated at about 3%, and now you can obtain THC products that are upwards of 15% in concentration. We care about this because THC in pregnancy, we know, readily crosses the placenta and binds to receptors in not only the brain, but other organs. And when questioned, cannabis users who are pregnant, a good portion, over half of women, continue to use cannabis products during pregnancy. And although many people still believe that cannabis is not something that one can become addicted to. Cannabis use disorder is actually a recognized DSM-5 diagnosis, which, along with other substance use disorders, has associated tolerance and withdrawal, which can have an impact on one's ability to parent. In a recent study looking at women hospitalized during pregnancy with cannabis use disorder, and if you look at the graph on the right, this is data from 2010 through 2018. And like many of the slides I'll be showing you, you can see this dark line represents the total patients with cannabis use disorder, and these numbers are increasing. When compared to pregnant women without this diagnosis, those with cannabis use disorder had significantly higher number of patients with anxiety, depression, and vomiting, which you'll see in the next slide are the most common reasons women acknowledge using cannabis during pregnancy. It does beg the question whether the cannabis is the cause or effect. Women will use cannabis to help alleviate some of these diagnoses, but also we know that cannabis can actually cause these problems. The authors of this article concluded that patients with cannabis use disorder should be followed very closely in pregnancy for concerns of worsening of mental health conditions. As I alluded to, in the last slide, this paper looked at reasons for women choosing to continue to use cannabis in pregnancy. And the most common reasons are to relieve stress or anxiety or to relieve nausea and vomiting. The reason I put this in here is that upwards of half the patients questioned also acknowledge using cannabis just to have fun or to relax. And while it's important to ask patients if they use cannabis products in pregnancy, it's also important to ask why they're choosing to use cannabis products, because there are alternative therapies, and depending on the reason for a patient's decision to continue using, treatment strategies will differ. And as you might imagine and are well aware, there are various ways in which women can consume cannabis. And while there's a lot of emerging data about the effects of cannabis use in pregnancy, what is still not entirely clear is if the mode of intake, specifically inhaling versus edibles, has an impact or makes a difference in terms of outcome. That degree of data is not very well understood at this point. So when thinking about use relative to pregnancy, this was a study that looked on a state level. It looked at 8 states comparing use of cannabis prior to pregnancy, then during, and then after pregnancy, to ask the question, do women decrease cannabis use, and what happens after the baby is born? You can see all states noted a decrease in cannabis use once the patient became pregnant, and then some states noted an increase in use once the baby delivered or after pregnancy. The other thing I wanted to point out in this slide is during the time this study was done, there were only 2 states where recreational cannabis use was legal. And as you might guess, those 2 states were Alaska and Maine, which makes one conclude that legality will likely inform a patient's decision to use. And in fact, other studies have shown the same thing. In this cross-sectional study by Skelton, they looked at women residing in states where recreational cannabis use was legal and found that they were significantly more likely to use cannabis during the preconception, prenatal, and postpartum period of pregnancy compared to women residing in states where legalization had yet to occur. And Colorado found the same thing when they looked at use prior to and after legalization for recreational use. And this is important information to know as more states are legalizing recreational use of cannabis products. What about use relative to timing in pregnancy with respect to trimesters? This was a study that looked at self-reported use prior to a woman conceiving and then compared to use during the 3 trimesters. The dark line represents the non-pregnant population. And again, like all other studies, this is from 2000 through 2020. The line is ascending, use is increasing. And the line that most closely represents the non-pregnant population is use in the first trimester, and then use decreases during the second and third trimester. The authors of this study concluded that use in first trimester is likely to be more common because many women don't realize that, in fact, they're pregnant. So does it matter if use is in the first trimester and then a patient stops, or if a patient continues throughout all trimesters with respect to outcomes? Well, that question was asked in this study, which was just published this year in JAMA. This was a multi-center cohort study. And unlike other studies where patients were identified by self-report, this study actually identified patients through urine samples, immunoassays, looking for cannabis. And what they found was ongoing cannabis use during pregnancy was associated with delivery of babies small for gestational age, delivering preterm, an increased rate of stillbirths, and mothers having hypertensive disorders of pregnancy. And when they looked at confounders, they found that significance remained even after adjusting for sociodemographic factors, body mass index, and medical comorbidities, including nicotine. Interestingly, however, when they divided up use, they found that cannabis use in the first trimester only, the significant findings above were not seen. So women who used only in the first trimester and then stopped using did not have neonates with these same risks compared to those women who chose to use throughout all of pregnancy. What about education? What impact does education have on a woman's decision to use? These were a couple studies done a number of years ago that demonstrated in women who received substance use counseling, over 3/4 of cannabis users were abstinent 151 days later and remained so until delivery. And in a second cohort of urban women receiving care, a positive urine screen for cannabis was reduced from 21% to about 2% after opportunities for education were provided during prenatal care, which suggests that, you know, the onus is on us as providers to provide education to our patients about use in pregnancy. So where do patients get their information? In a study in 2016, the conclusion from this group was that when providers did counsel patients about use, the focus was actually on child protective services and legal consequences rather than the medical or health effects of marijuana or cannabis use, which very much is one of the reasons that patients oftentimes choose not to disclose this information. And I have a slide that talks about that in a bit. In a more recent study, however, of 3,000 Colorado mothers surveyed between 2018 and 2020 about use during pregnancy and breastfeeding, upwards of 69% of patients noted that healthcare workers were identified as the most common trusted source of cannabis information. In addition, these same patients also noted that word of mouth, cannabis websites, and cannabis stores were also trusted sources of information during pregnancy. So patients are still deriving a fair amount of information outside of their provider in making decisions about use during pregnancy. This is a warning label that is posted in all dispensaries in Colorado and Oregon, and several other states actually that mandate warning labels in dispensaries. And full disclosure, I actually attended a cannabis commission meeting in the state of Rhode Island. Rhode Island has recently approved legalization for recreational use of cannabis. And I recommended that warning labels such as this be considered to be posted in dispensaries in Rhode Island. And then I actually looked up to see if there was data supporting the value of these warning labels. And I am humbled to say that the data isn't very good. This is a study that was published just this year looking at that question. It was a cross-sectional study of over 2,000 pregnant, recently pregnant women where warning signs were posted in their states. And what was found was that cannabis users believed use was safe in pregnancy and patients should not be punished, whereas non-users believed that use was not safe and that users should be punished. And they found that there were no associations with living in a state where warning signs were posted and reduced cannabis use in pregnancy. And they found that users express message fatigue and mistrust of the information, so that perhaps these warning labels are actually not having the effect that the providers hoped in posting these labels. And this is a set of graphs from that article, and I'm not going to review all of them, but I point you to the graph on the upper right-hand side labeled B, where the question was asked, I'm tired of hearing how cannabis use is bad for my baby's health. And the set of bars on the far right were from those people who used cannabis during pregnancy. And the light and dark blue bars are those who agree and strongly agree, whereas the yellow and orange are those who strongly disagree. And so you can see in those patients who use cannabis strongly agree with the statement, I'm tired of hearing about it. If you look at the bars to the far left, those are patients who chose not to use cannabis. And in this population, they're not tired of hearing about it. So there's clearly a dichotomy. The presence of these warning labels may not, in fact, change people's opinion. Which leads to the point of how patients are receiving information, where they get their information from. I put this slide in here. It's not specific to pregnancy, but it is specific to cannabis. And I think it's important to just point out how the media plays a very important role in how patients perceive and receive information. This was a study looking at the placebo response and media attention in randomized clinical trials assessing cannabis-based therapies for pain. So the group evaluated the size of the placebo response in randomized trials comparing cannabinoids with placebo to treat pain and to correlate these responses to estimates of media attention. So they had 20 double-blind randomized controlled trials of almost 1,500 patients where they measured pain intensity by self-report. And what these studies showed was that there was a significant reduction in pain intensity in response to the placebo. And they didn't find a difference between the placebo group and the cannabis group. Furthermore, when the study was not biased, so when the patients didn't know what they were receiving, the placebo effect was actually greater. However, the media focused their attention on the cannabinoid response, focusing on the fact that cannabinoids helped relieve pain, and they chose not to focus on that placebo did the same thing, with the point being that high media attention surrounding these trials with positive reports, irrespective of scientific results, which basically said placebo did the same thing, very much informs the public's perception of the positive response of cannabinoids when in fact placebo does the same thing. And I put this in here to just emphasize how it's very important that some of the media attention that this product receives is not always the full scientific information that studies are finding. So in thinking about patients' perception and their decision to continue using cannabis in pregnancy, this was a study in California that looked at people's experience in discussing cannabis with their providers. California is one of the orange states, so it is legal both recreationally and medicinally. Most patients in this study reported daily use both before and during pregnancy, but most did not disclose it to their providers for fear of Child Protective Service reporting or judgment. And few providers, they stated, actually initiated discussions about cannabis, and some participants interpreted this as tacit endorsement. And when discussion occurred, similar to the previous slide, often conflicting health messages and legal threats were provided. And these are some quotes and examples of the perception and the experience that patients received. I was nervous they would take my kid if I said I was smoking weed. I've wanted to share with my doctors, but I'm not trying to invite any complications that I don't need, so I've kept it to myself. The doctor gave me the okay to smoke because I had horrible morning sickness as long as I don't use tobacco products, just use straight out of a bong or a bowl. What they said was using cannabis is all right. They're not cheering me on, but if it helps with eating, go for it. Your baby will come out underweight, not fully developed with birth defects. We want to make sure all moms understand. My midwife was supportive, but warned me of other staff who would report me. Let's keep this backstage here with you and I. So clearly a bit all over the map. We in healthcare certainly give mixed messages, and these data support this as well. In a study out of Colorado, 70% of dispensaries actually recommended cannabis products to treat pregnant women with nausea and vomiting. And in an additional study, pregnant women with severe nausea and vomiting, as I've alluded to before, had a 4 times greater odds of using cannabis products compared to women without these diagnoses. And in a study on lactation professionals, 85% of them encouraged breastfeeding in women using cannabis products. If you have an opinion or a thought about use in pregnancy, you can probably find an article in the literature that supports your belief. There is a lot of different information out in the literature because some studies are old and outdated. There are other studies that are small and retrospectively collected their data. If you're looking for data on the effects of breastfeeding only, you'll have a hard time finding it because most women who use cannabis during breastfeeding have also used in pregnancy. So you've got the effects of fetal exposure as well as now exposure in breast milk. And data is oftentimes confounded by other exposures that may impact outcomes, such as smoking or alcohol, other medications, or populations most likely to use, all of which may impact the outcome for the baby. In addition, the older literature may not take into account the concentrations currently seen with cannabis products, as I mentioned earlier. And also many studies are ascertained by self-report, which in the substance use literature may underestimate use. And so that can lead to contrary findings from one study to another. So the data that I'm going to show you moving forward is all recent. It's all within the past several years, trying to address some of these challenges to provide you with the most updated evidence that the literature has available. Many of the studies that we have seen on cannabis make conclusions about associations between cannabis and outcome rather than cause, because we can't always demonstrate cause. But this is a study that actually tried to look at mechanisms or causes behind some of the outcomes that we're seeing in newborns. This was a study that used a non-human primate where observations are translatable to human pregnancies to better understand the mechanism behind some of the untoward outcomes that we are seeing with fetal cannabis exposure. They gave pregnant non-human primates edibles, and then they looked at the offspring. They studied the offspring's epigenome. Epigenetics is a change in the way our genes are expressed without actually modifying the DNA. So some outside or external exposure is impacting how our genes are being expressed. And in this particular study, the exposure is cannabis. And what the authors found was that prenatal THC exposure altered both placental and fetal tissue epigenome, so the way in which the genes were expressed in regions of the genome that have been known to be associated with autism spectrum disorder, as well as anxiety-related behavior, both of which have been seen in children born to women who have used cannabis products in pregnancy. What about the impact of cannabis, paternal cannabis use? Let's not lay all the exposures on just the mom. We know that compared to non-users, men who use cannabis tend to have lower sperm concentrations. And when looking at preconception exposure, there is an associated with widespread DNA methylation in sperm. DNA methylation is another epigenetic change of gene expression. And so what can happen is that when they've looked at the genes of men who are cannabis users, they have found that there's a change in the way the DNA is expressed in the genes, specific to areas involved in early neurodevelopment and in other areas that are implicated in certain cancers. What has not been well understood at this point is whether these epigenetic changes can actually be passed on to offspring. If these men go on to father children, if these changes that are being seen are going to be seen in their children. This was a study that looked at newborn outcomes in babies. They had two groups, an unexposed and an exposed group. And unlike some of the other studies that used self-report to include patients, these patients were included based on urine drug screens. And again, they matched for other confounders so that both groups were basically as identical as they could be with respect to all the to nicotine, alcohol, polysubstance, age, socioeconomic status, race, marital status, and parity. They included two distinct U.S. cohorts. The only difference was cannabis exposure. And what they found was, compared to the unexposed group, cannabis exposure was associated with babies being born of lower birth weight, earlier gestational age. There was a higher percentage of preterm births, lower APGAR scores, and a higher likelihood of admission to NICUs. This was a study out of Canada that looked at a large population of over 1 million patients. This is a self-report study adjusted again for these confounders listed here. They found that prevalence of cannabis use was about 2%. It was more commonly seen in women who were less than 24 years of age, who were either underweight or obese, came from rural or the lowest income quintile, and had a high co-occurrence with other substance use. And in looking at the outcomes, they found there was a positive association between prenatal cannabis use only and lower birth weight, preterm birth, small for gestational age. And in this study, they also found an association between some major congenital anomalies and in the mothers delivering by cesarean section and gestational diabetes. This study out of New York looked at brain structure in a small population of 29 neonates compared to a matched unexposed population. Cannabis exposure was associated with slowed brain growth disproportionately in regions that grow more slowly and accelerated growth in regions that grow more quickly when they looked at MRI imaging. And again, when they controlled for other confounders, they found the results were unchanged. They also went on to follow these babies developmentally for their outcome for the first year of life. The cannabis-exposed children did not fare as well, and so their conclusion was that perhaps the findings that are seen on MRI may be related to the worse outcomes that they're noting in the first year of life. In thinking beyond the newborn period, this was a study that looked at children at 7 years of age. This also was out of Canada. They were trying to establish an association between prenatal cannabis and neurodevelopmental outcome, and they found that children exposed to cannabis prenatally, only cannabis, had a 50% increase in autism diagnosis, even after controlling for other confounders. And again, they caution, they're not saying that cannabis causes autism, they're just noting that there is an association, which, you know, as I mentioned earlier in the non-primate study, they did find epigenetic changes in those regions that have been found to be associated with autism. The ABCD study, or the Adolescent Brain Cognitive Development Study, is a very large prospective longitudinal study looking at children between 9 and 10 years of age. It's a very large study of over 12,000 patients enrolled from 21 sites, looking at outcomes from various exposures. Cannabis happens to just be one of them, and compared to an unexposed cohort. This is now looking at children as they become a little bit older. So these are now 9 to 11-year-olds. They've noticed an association with greater psychopathology, such as psychotic-like behaviors, attention problems, problems with thought, social problems, and sleep disorders, initiating and maintaining sleep, problems with arousal, sleep-wake disorders, and excessive somnolence when these children have been exposed to prenatal or fetal cannabis exposure. This also was a study that came out of the ABCD group, looking at adolescents' decision to start using cannabis. What, if any, risk factors increase the likelihood of a child deciding to use cannabis as an adolescent? Up to 12% of 14 to 15-year-olds in the United States report a lifetime use of cannabis, which is associated with an increased risk of cannabis use disorder. And so the ABCD study looked at prospective risk factors that are associated with early onset use, so use at age 13. And what they found was that prenatal cannabis use by mothers, was associated with the largest risk for cannabis initiation. And this risk remained when they controlled for tobacco use, alcohol use, family or parental alcohol or drug use, or prenatal alcohol or tobacco exposure. It was cannabis use prenatally that had the greatest risk factor for an adolescent's decision to begin using cannabis. What about breastfeeding? I'm just going to sort of turn my attention to nursing. We all know that breastfeeding offers an unmatched beginning for children, decreasing overall mortality and morbidity for both baby and mom. Moms who breastfeed are healthier. Families who breastfeed save money. Communities reap the benefit of breastfeeding, and the environment benefits when babies are breastfed. However, we also know that pre- and postnatal use of cannabis is highest among underserved minority women, whose health morbidities may actually worsen if we tell them breastfeeding should be avoided if cannabis is being used. So are we depriving the newborn the benefits of breast milk or breastfeeding if we tell a patient that? And as I mentioned earlier, the data is not very good when looking at purely exposure in breast milk, because many of these studies are confounded with fetal exposure. So what should we tell our patients? Pump, discard? This study done in Colorado tried to get at that issue. They looked at patients who had an intention to breastfeed who were using cannabis and tried to enroll patients willing to abstain for 6 weeks. Of 394 patients, there were 105 who were eligible and 25 enrolled, but only 12 remained abstinent. So about half of their sample was able to abstain from cannabis products for the 6 weeks. And they looked at maternal and breast milk samples for cannabis 2 to 5 times per week for 6 weeks. They found that all participants had detectable THC at 6 weeks. And of 7 women who abstained more than 5 weeks, the mean half-life of THC in breast milk was 17 days, with a projected elimination time of greater than 6 weeks. So to say to a mom, you should pump and discard your milk for a week or two, it's not really realistic. It's a lot to ask a mom because cannabis or THC is going to remain in breast milk for a long period of time. So what should we how and what should we advise and guide our patients? I think it's important to think about our basic principles of ethics. Our goal as providers should be to help our patients have a healthy pregnancy and not force them to change behaviors or punish those who disclose particular behaviors. As providers, our obligation is to educate. And when this doesn't happen, these sorts of things have occurred. And this has happened in our hospital as well. Patients leave AMA or they choose to deliver at home. Patients' behavior escalates. They've lashed out at staff, especially if they're getting mixed messages. Child Protective Services have had to get involved. And what ends up happening is patients receive inconsistent or mixed messages. And that doesn't serve anyone, least of which is the family. So what should our message be to patients? A better understanding of why women are using cannabis during pregnancy is important to enable a conversation of alternative therapies for which there's extensive safety and efficacy data. I've had conversations with patients who tell me they want to use something natural. They'd rather not use a drug, a toxic, medication like an SSRI, when in fact, the reality is there's far more safety and research data on the safety of SSRIs in pregnancy than there is with cannabis. Advice from medical professionals should be consistent. Pregnant and lactating women should avoid cannabis, and parents caring for developing children should be advised to maintain abstinence. Treatment programs should be available, accessible, and gender and culturally specific. And the purpose of screening is to educate and allow for treatment and not to punish or prosecute. So how do we educate? This is an example of a poster available on the ACOG website as a tool to begin a conversation. I went on your website and I was really impressed at the available information that's patients in Maine have access to. Not only does it talk about general effects of cannabis, but it also talks about specific information relative to what's happening in Maine. With respect to the numbers of women who are using cannabis products, but also information about how much providers are actually discussing this with patients. In this particular slide, 79% of expectant mothers reported that their provider asked them about cannabis use, but only 38% reported that providers advised them not to use during pregnancy. And then the second slide talks about nursing and breastfeeding. So congratulations to y'all in Maine. You're doing a great job with respect to trying to inform patients. At Women and Infants, we have guidance and literature for patients. We inform our patients about use of cannabis in pregnancy. We talk about our Academy's recommendations against use in pregnancy. We also talk to them about the laws regarding mandatory reporting in both the states of Rhode Island and Massachusetts. We verbally screen for cannabis use. Those who screen positive, we educate them. We don't automatically ask for toxicology screens, but those who continue to screen positive will be asked to submit to a drug test. We do want to provide the opportunity to stop using and allow patients to exercise autonomy. With respect to nursing, we have a guideline which has been revised multiple times. With respect to cannabis, Our statement reads, if after receiving education that's been documented in the medical record, a parent who's using cannabis products chooses to breastfeed a baby, the parent's choice will be respected and the parent will be provided with the same services afforded to all breastfeeding parents. It's important patients understand the lack of data should not be interpreted as endorsement of safety, and parents should be counseled to avoid smoking cannabis during breastfeeding. This is a little snippet from a document that we give to parents in educational form. These 3 bullets are relative to cannabis. States that using cannabis in any form during or after pregnancy may be harmful to your baby because it is passed through the placenta and breast milk. Babies who are breastfed by a parent who's using cannabis have an increased risk of developmental delay or difficulties. Choosing to use cannabis while breastfeeding is a choice that should be discussed with your provider. Using non-prescribed substances, tobacco, and or alcohol will not prevent you or your baby from receiving care. Your providers respect you, and we're here to help you. And then it goes on to talk about what the law says. With respect to the law, I looked up what Maine says. You all know that better than me. This was the most recent one I could find. And the statement says, additionally, under this statute, healthcare providers are required to report to CPS any situation where a newborn is demonstrating withdrawal symptoms that require medical monitoring or care beyond standard newborn care when those symptoms have resulted from or have likely resulted from prenatal drug exposure, whether the prenatal exposure was legal or illegal drugs. In the state of Rhode Island and Massachusetts, even though cannabis is legal for recreational use, we are still obliged to report. And if I'm reading this correctly, it sounds like in Maine you are as well, unless it's changed or I'm misinterpreting this. So what does reporting, what impact does this have on prenatal care? This was a study that asked that question, the association of child reporting policies and a woman receiving pre and postnatal care. This was a cross-sectional study of over 4,000 women from 23 states where reporting was required to examine the association between child state abuse policies with receipt of prenatal and postpartum care. And as you might imagine, both policies were associated with reduced receipt of prenatal and postpartum care and later entry into prenatal care. And several of the slides from the studies that I showed earlier suggested that women are hesitant to report use for this fear. So these are my key points, and I will end with this. There is movement to change cannabis legislation from Schedule 1 to Schedule 3, which will broaden research opportunities, which is a good thing. However, in lessening restrictions, it's going to impact availability. And as I've shown you before, legality does inform frequency of use. So cannabis use in pregnancy will likely increase. And there's a growing body of evidence associating cannabis use in pregnancy with epigenetic changes in the fetus, neurobehavioral morbidities in children, and the potential to inform decision-making regarding use as an adolescent. And our role should be to educate, support, respect autonomy, and not to punish our patients. So that is the end of my talk. I think I actually have used every minute available to me.
Mara, that was excellent. So much great information. There was a lot of great conversation in the chat. I see some really great questions in the Q&A, and I'm going to download the report, send it to you to get your answers so I can share that information back with the participants.
Okay.
If you want to pop in the chat and answer some things that were talked about in there, that would be great. And we are on break now for the next 10, 12 minutes. We will be back at 1:30 with the importance of doulas. All right. Thank you.
Thank you.
All right, welcome back, everybody. Good afternoon. I am very excited to introduce our next presenters, Dina Day and Gia Bartolomeo from Community Doulas. They're a nonprofit organization whose mission is to improve overall birth outcomes by providing evidence-based education, continuous professional labor support, and community connections to growing families in Maine. They are also dedicated to growing the doula community by providing new doulas with education, doula mentorship, and connections to expectant families. Dina received her degree in community service work from Trillium College in Kingston, Ontario in 2010, and completed her birth doula training in 2016. She went on to train and become certified as a bereavement doula, a death doula, and a full spectrum doula. She has continued to advance her education through coursework in advocating and counseling for women and children, vaccines, AIDS, and psychological first aid through George Brown College, the University of Michigan, the University of Pennsylvania, and Johns Hopkins University. Dina worked extensively in Kingston as a counselor, advocate, doula, and a leader in birth work, specializing in serving persons with addiction and mental health challenges, and served as the director of programming for the Doula Support Foundation until moving to Maine in 2023. Dina joined the Community Doulas in May of 2023 and serves on the board of directors as the Director of Community Involvement. Gia, a native Mainer, enjoyed a 32-year career in IT and education in Massachusetts and Connecticut until 2008, when she returned to Maine to retire. Since then, she's been helping nonprofit corporations with finances and serving on boards in Maine and Massachusetts. In 1985, Gia began assisting birthing women and those without partners as a volunteer while living in Hartford, Connecticut. She received formal doula training in 2009, and since then she has served birthing women and families in hospitals and home births throughout New England. She retired from attending births in 2020 to focus on mentoring and supporting new doulas. Gia now serves as the interim executive director, preparing to grow the Community Doulas organization to be a leader in maternal health partnerships in Maine. Welcome, Gia and Dina.
I'm going to start with a slideshow, just explaining a little bit about what doulas are and what we do. And then we have a film for you to watch, and then Dina's going to pick up after that. So I'm going to get started. Share my screen. Are you seeing my screen? Let's see.
Yes, we are.
Okay, good. So we'll start with what is a doula. Most of you probably know what a doula is, but maybe some don't. So we're just going to go through this. Birth doulas are a birthing person's basic buddy. And postpartum doulas will support a person and a family throughout the first year. Additionally, we serve as pregnancy and loss doulas, which gets people through the hard times of both pregnancy loss, birth loss, for many reasons. We support our clients in 4 specific ways that are very differently from what hospital staff and labor and delivery nurses do. We provide physical hands-on support by soothing with touch, massage, helping to create calm environments. We assist you with water therapy, getting in and out of the tub, applying warm or cold, assisting the birthing person in walking to and from the bathroom, giving ice chips, food, and drinks. The labor and delivery nurses in our hospital are very busy providing health care and making sure that some of those things are happening, but oftentimes they're serving more than one person at a time. And we're there. We have a continuous presence from prenatal through postpartum. So we know our clients, they feel comfortable with having us around. It's not getting to know a new person and setting new boundaries. So we can provide reassurance, validation, encouragement, and praise. We help the birthing person see themselves or their situation more positively. And even after the birth, just sort of help the person understand what what was happening, how that was happening, and just really understanding the process. We guide the birthing person and their partner through labor. We are trained in techniques such as breathing, relaxation techniques, movement, and positioning. I've walked the circle around the nurse's station hundreds of times with patients to help them just be more comfortable during birth. Standing and walking can often expedite labor, and explaining to them. We can explain medical procedures before they occur by having those discussions ahead of time and in a home setting with a client. We can help explain what an epidural is. We can't give them advice about whether or not to get an epidural. That's not our job. But we can help them find evidence-based information and explain those procedures prior to them happening so that they can make informed choices. We can encourage in advocacy. We don't advocate for our clients. We give them the ability and train them to advocate for themselves in many situations. We can encourage questions and verbalizing their preferences, support their decisions, give them space and time to make those decisions by discussing the options prior to going into labor. We can often facilitate communication between the parents and the care providers, in that we know we can cross those language barriers sometimes more easily than a pregnant person or a person in labor can. And we can work within the community to make positive changes for people who birth in Maine, by supporting the doula community, by becoming more engaged in the provider community. And hopefully this will play. This is our little video, and I'm going to start it. This takes us through a doula's relationship with 3 different clients, from prenatal through postpartum, and it's in their voice and some of our voices. So enjoy this video.
There's no sound. Did you share the sound with the video? I think
Oh,
there's something.
hold on, I did. You know what? I'm going to do this a different way. Hold on. Is there sound on this?
We're not seeing it. I don't see it. Are you still
You're not
sharing
seeing
your
the video now.
screen?
Oh, no. Hold on. I'm just sharing the wrong screen here. Hold on. That's me, right? I want to share screen. This one. Share this one.
It's quite an experience.
Is there sound now?
Yes, there's a lot of feelings to it. You guys are those, I am pregnant with twins. It's definitely a new step. We're going from 1 to 3, which is, I think, going to be sort of an adventure, but an exciting journey. When I had my son, I was 24. At 13 weeks, I was driving on the highway and I just started bleeding. And it was like driving 60 miles per hour. So I didn't know what was going on. I went to the hospital, got checked, and I spoke to my nurse, and she said, you're definitely going to need more advocacy. You're going to need more support, especially because now we know that you're a bit more high risk. And so I was given the doula, and she went through the entire process from prenatal to birth to postpartum. That's the beauty of the doula. A lot of people only focus on birth. They don't focus on just the realities of the entire process.
So is there anything like really glaringly on your mind about how you'd like this birth to be different from your first? Something that was missing from the first, or?
Well, the environment wasn't necessarily comfortable because it felt like I was in a surgery with my son. It's like 50 lights on, and I couldn't.
What happened? I'm sorry, I don't know why that started over.
Giving birth, it's quite an experience, which has there's a lot of feelings to it. You got some of those, please. I am pregnant with twins. It's definitely a new step. We're going from 1 to 3, which is, I think, going to be sort of an adventure, but an exciting journey. When I had my son, I was 24. At 13 weeks, I was driving on the highway and I just started bleeding. And it was like driving 60 miles per hour. So I didn't know what was going on. I went to the hospital, got checked, and I spoke to my nurse, and she said, you're definitely going to need more advocacy. You're going to need more support, especially because now we know that you're a bit more high risk. And so I was given the doula, and she went through the entire process from prenatal to birth to postpartum. That's the beauty of the doula. A lot of people only focus on birth. They don't focus on just the realities of the entire process.
So is there anything like really glaringly on your mind about how you'd like this birth to be different from your first? Something that was missing from the first, or?
Well, the environment wasn't necessarily comfortable because it felt like I was in a surgery with my son. It's like 50 lights on, and I couldn't concentrate. I think Courtney shared that you can not have so many lights on.
Right. Yeah. The last birth I was at, the nurse actually brought in some candles that had the battery operated.
Oh, that's wonderful.
Up for the woman, so it's really nice.
Yeah. I want to go more that route, and I think that can help me to just just feel a lot more comfortable in the room. The other thing is, I'm not sure, but with twins,
doulas contribute quite a lot to the patient care team. First of all, doulas usually enter into the picture on the prenatal side of things, offering prenatal education and informing clients of what their choices are and reminding them that they do indeed have choices in birth. As professional labor support people, they come into the birthing space, and because they already have an established relationship and some continuity of care, have already heard what the choices are of the client. They can make sure that there is space for that client's voice to be heard and respected and honored. Getting to have those conversations in your own home, maybe the piece that allows somebody to really open up and say what's been on their heart and their mind.
So is there some worry, apprehension about that?
Yeah, exactly.
I think it depends on how you feel at the time. Like whatever supports you need to kind of make your life manageable the first couple of weeks. Yeah, because it's a huge change. So you can really just focus on being a new mom of twins and not anything else.
Gotcha.
Yeah, because I think that it's really
most of the time we get involved at around 20 to 30 weeks, and they're really starting to think about what is this birth going to look like? How is that going to impact me? And oftentimes, I think when you're in a person's home and answering those questions, they're more relaxed. They can think about the questions. They know what those questions are. you know, it's not that they can't ask their doctor those questions, but we lend that more personal, continuous emotional support to a family through the birth process and beyond.
You look so good. Oh, there we go. She's growing so nicely. Good job, Mama. Awesome. I became a doula because I realized that when I gave birth to my daughter, there was something missing. The OB is really focused on the physical health of the mom and the baby, and I am looking at the mental health and the emotional health and spiritual health. Hopefully by Christmas we can get you into a nice place, and I'd like you to be nearby too.
Yes. Bart's only been going nowhere. You're stuck. You're stuck in the family.
I want to sunshine.
Yes, you are. And then everybody gets a hoot out of your name. Like, is that her real name? I said, no. I said, but I liked it.
Community doulas has been serving really a broad spectrum of populations in Maine. Lately, we're seeing a lot more birthing persons who are in recovery or in less than perfect home situation. And I think a doula can just get to know that person a little bit better and be able to provide them the support that they lack.
You can kind of do tummy time like this and let her practice having her head so she doesn't have to be so flat on the ground because she's still developing her muscles in the back of her neck. Yeah. Yes. And how's recovery stuff going? I'm really proud of you for coming to the meetings and also.
Yeah, I'm trying to do it. I do want to do it once a day, no matter which time it is.
Yeah.
So I just getting used to that. If I haven't really been getting used.
I think some people in our society look at addiction as a moral issue, but it is a disease. And I firsthand know that. I've been 6 years sober from alcohol, and it's really helpful to share that experience with other, parents that might be in recovery or struggling with substance abuse. I'm able to look at the person that has the disease and approach from a different way.
It's that feeling of security and safety, especially me having traumatic issues with professionals. Me personally, I probably wouldn't have advocated for myself without that feeling of, you're backing me up. It definitely made me feel more comfortable and okay in that sense of not being scared. And the day that I got to bring her home, I feel like a lot of that was because you had, I felt comfortable. You had been there, you had talked me through some stuff. You were just meeting you. I mean, I feel like we connected like that from the beginning. That's why I was able to advocate for myself, because I don't always have that ambition to do that. So,
we might have, women who have just been in a system their whole lives or a good part of their lives where they weren't, say, treated with a certain amount of dignity. And I think a doula helps them get that back.
It's changed my life having sunshine in it. 100,000,000%. It would have been different, I feel. And her being there and just being that open support has been amazing. And I feel like I don't know what I would do without it.
They are very vested in your emotional and your mental wellness. They're also pretty level-headed in terms of the medical piece of the birthing process. So to have that level of support where someone can move through those two areas, it's really important.
when we're doing the work of labor, especially when we're in active labor, we ideally want to be really inward in our bodies doing the work. And that's not a great moment to try to build rapport with someone. It's not a great moment to try to ensure that someone has read our birth plan or has had access to it.
Yeah, because you're not going to want to be up and about with that new baby. Maybe right now until she gets to walk around a little bit, or or right now, just for 15 minutes. Yeah, minutes to see if it's allow that BVA to put pressure on that cervix. Gravity helps us here.
Having somebody else in place who can be that point of continuity, whether it's 8 hours or 24 hours, and can continue to advocate and support the birth plan can be really critical.
It really should be a part of the birthing experience for all mothers, not only those who know about it, who have access to it, but it really should be a part of how we experience birth. And you're not by yourself. You know, I think too many times this process, especially in the US, you have to endure it by yourself, and some of these challenges. But if you have someone there, you know, you have someone who you can lean on and who can help you navigate this just a bit more easier.
The most important thing that I've learned is that like everyone's needs are different. Some people want you to come into their home and teach them breathing techniques or talk to them about birthing options, but other people have needs that are just like so much more about like survival. Hey Denise, can you remind me the code to dial in to open the door? Okay, thank you. See you soon. When we visit the clients in their home, it helps you understand what the living situation is like and help to prepare them for the things that parents need before the birth and after the birth. You get a better feel for what their lives are like, but you also just connect on a deeper level. Oh, good. Oh, she's so big. Postpartum support is like having that advocate when you're too tired to like know which research or who to call. Yeah, I'm just going to eat something real quick. Mama's gonna eat and Alana's gonna eat. Mommy is a really good chef.
We want to take a holistic perspective of childbearing families, but we have to consider what is happening in their life and what's happening in their home. Many people are facing big life transitions. Having a baby obviously is a really big transition. Many people are also facing the transition of having recently moved to the US or recently moved to Maine, that they have additional barriers.
You haven't been here and looked yet.
It's harsher.
Yeah. Do you need jackets?
Yeah, I do.
Okay. So, how about winter clothes?
My name is Denise. I am from Angola. I'm 28 years old. I'm a new mom of a baby girl. I entered in Maine as a refugee. When I arrived, I was 8 months pregnant. I didn't know anyone when I arrived here. One of the guys that was working at the GA, every day would leave me like leaflets. And one of the leaflets was about the DONA community. I talked to a lady, really nice lady, and then Rhode called me, and we started getting in touch and knowing each other. But even if I had all the money in the world, I could never pay for what she has done for me because it's really hard. I remember when they told me that I was going to have a C-section, and I was so scared. But you were there. And that kind of comforted me. I knew that, I was safe. I'm really thankful for that. You were the first person that I saw and I woke up. So that maybe you were too tired and go for a while. But then you woke up and you were there and I was like, oh, she's there. She's here.
With all the support that the parents might have, they think that they have to just be strong and just go through it because that's what everyone has done, or their parents went through the same thing. They're allowed to cry, they're allowed to be feeling whatever they're feeling. Even if they have a healthy baby, they're still allowed to feel whatever they feel.
And when you watch a birthing person's face, you see all of those emotions, every emotion. There's joy, there's sadness, there's pain, and there's elation in the middle of all of that and layered on top of one another. A birth, even though it's joyous time, is a traumatic experience. A birth is a traumatic experience for everyone. I want them to know that we'll be there afterwards. We'll be there for her for, the period of time when, she's learning to be a mother.
It's come to me that the importance of doula is you realize that a lot of persons may not have the support that we have. You having your mom or your sister to be a part of it at certain point because at one point it just made you get. So I couldn't do it alone. So just think about just having that extra person there really means a lot.
Yes.
At least that person can have your corner. So what about with these persons out there who with the child father is not there, not present, they can't get time off like I do. To have a doula, somebody advocating for you or to be there for you is key. So I mean, if anyone doesn't know about it, needs to know at this point because I see the importance of it where, it's not just a doula, it's a family.
So I want to thank you all for watching, and I'm going to hand this over to Dina.
So exciting.
Okay. Yeah, I got to go back to where I was. Hold on.
So we're just going to very quickly go over what do our clients get. They're usually referred to as doula packages, although some doulas just may have one. Some have multiple based on what their clients may need. But generally speaking, you have prenatal visits that starts with an initial, usually free consultation. And then you have 2 to 3 prenatal meetings during which we provide information support, deciding on comfort measures that are going to be best for our clients, and just getting them ready for labor and birth. Then we have the actual labor support, which we usually go on call about 38 weeks. And that means 24/7 that client can get a hold of us. We do continuous labor support once we're called in, unless we need to call in a backup. And usually support for the first 3 hours or so post-birth to make sure that our clients are bonding with their baby, that if they want to breastfeed, that initial contact is made. And then postpartum, it's usually 2 to 3 visits. Some doulas do more, some do less. But just to make sure that things are going all right once they get home, or if they had a home birth, they're already home, so that's great. Postpartum doulas do things a little bit differently. It's usually packages based on hours, unless it's overnight care, and then they may have a set fee for an overnight visit. They teach infant care, so a large one is infant feeding, and also sleep. That's probably the number one thing that new parents reach out about, other than what is this rash, is how can I get my baby to sleep? And so some doulas have extra education in sleep hygiene, not just for babies, but for the whole family. Overnight care, giving parents that extra sleep that they need. They may not have people that can come over and stay the night. So some doulas do overnight care where they take care of the baby and maybe some quiet chores. Other things that they do during postpartum is light housework. They can do meal planning or preparation, and also building that community, so that once you're done with your postpartum doula, you're not just left alone. You have people who are willing to step in and help you get through that first postpartum period. So for loss doulas, which I am, I sort of break it down into expected losses and unexpected losses. With expected losses, it looks a lot just like a regular birth doula package, except we are preparing not only for the hello, but also the goodbye, and how to balance grief during that time. What's going to be important for them? What memories do they want to make? Which ones do they feel that they don't want to take home with them? With unexpected losses, you sort of have to hit the ground running. You have to create that relationship in the moment, which can be challenging, but also creating space, not just for the grief, but also the shock that they're probably going through. I do a lot of post-loss work because people don't necessarily know that there are doulas for losses, or don't think to reach out. So I see people that either I've already worked with or are reaching out sometimes in the first 2 years after a loss, looking for somebody to help guide them through their grief and their mourning. I usually meet weekly or bi-weekly. The biggest feedback that I hear is that I listened without judgment, that they were able to say the things that were in their head that they thought might make them sound crazy, but it's just normal. It's normal grieving, and to validate that was always said to be very powerful for them. I also do a lot of work on creating a grief journey, what tools work for your client already in their life. They usually know what makes them feel comfortable and soothed. So you can use those through the grief journey, and also legacy work, not necessarily finding meaning in the loss, but finding meaning in life, that they often know, little intuitions about who their baby was going to be, the person they envisioned raising and seeing in the future. And it affects them. They take that with them. And legacy work honors that and gives meaning in a way that's comforting. So other types of losses that we support as loss doulas are adoptions, giving up a baby that you've carried and may or may not see again, depending on the kind of adoption you're going through. But we also, on the other side, sometimes work with parents who were adopting and the adoption fell through, which can be hard because the baby is still out there, but you're not going to see them. And that grief can be hard to come to terms with and can feel a little brushed off. But but is still important for them to go through their grief journey. Also child apprehensions, that can be from Indigenous babies being scooped, but also mental health and addiction diagnoses can end with a child being taken from their parents after they give birth. Which brings us to clients with mental health and addiction challenges. Now, I didn't start out as a doula. I started out as a community worker. I primarily worked as a support worker in a peer support drop-in center, which I loved. And I never planned on being a doula, but I kept seeing it being advertised in my area. And so I took the training. I took the training through DONA. And then I felt that there was just things missing in the training. So I also took my training through stillbirth day to learn how to support losses, which became my passion. But because of my background in community work, I wanted to also support people from the community that I had already supported. So I looked for some programs. There were two in my community in Kingston, in Ontario, called Motherwise and Thrive. And they both provide resources and support for parents who have addiction challenges, who may be in recovery and they may be not. But the workers there couldn't go to the hospital with them to make sure that things were going well for them. They couldn't be there for the labor and delivery. And so they found that it was really useful to have me serve their clients when they wanted to, so that I could be there, I could be their eyes, and I could also be the person that they know is going to be on their client's side, that's going to support them and treat them well and give them the best birth experience that they can have. And so while I was doing that, we were also developing a program called the Doula Support Foundation. We wanted to provide support for people who could not afford to have a doula. And that was one of the programming choices that I made while we were building it, was to have a program called Empower that would support people who have mental health and addiction challenges, and to provide training for doulas so that they know how to support those clients, that they know what the challenges are going to be for them. And so when I came here to Maine, I immediately looked to see if there was anything like Doula Support Foundation. And I found community doulas who I am very happy took me in and made me their director of outreach. And overall, we see people who are living at or below the poverty line, or people who, due to the rising cost of living, cannot afford to have a doula, but they deserve to have one if they want one. There's also overlaps with the low-income community between addiction and mental health communities. So we do see people who have those challenges. So other than the overlap between low income and mental health and addiction clients, we see a lot of generational poverty, people who come from backgrounds that are poor, that their parents grew up in poverty, that their grandparents grew up in poverty. And in these communities, there's a lot of distrust of systems. They don't believe that when people say that they're going to help them, that they believe in them, that that's really real, because their lives don't reflect that. They can also have feelings of being isolated and alone and disregarded. And so that's something that we really try to work on when we meet our clients. We provide services that are normally unreachable without losing quality. There are doulas who want to provide free services, but then they take off prenatal or postpartum visits. They sometimes will just do the birth without doing any of the education so that they can provide the free service. And we don't do that with community doulas. They're getting everything that somebody who could pay for a doula is going to get. And birth makes people vulnerable. It's a vulnerable situation. And so we recognize that putting vulnerable people in a vulnerable situation means that they need more support. They may not have experienced unconditional support. We really don't care where people come from or what their lives have been. We are going to be there for them and believe in them and give them that support. We try to focus on positive experiences, even if the outcome is going to be negative. If they are going to leave without their baby, that they are still treated with respect and told, we know you can do this. And overall, positive, empowering experiences are more likely to enable our clients to maintain their recovery or seek recovery because they leave knowing that somebody believes in them and that if they need to reach out, they can reach out. So Gia is going to continue talking about doulas and doctors and community workers and how we can all come together and what we see as the problems that have been there so far.
Hi, I'm back. I'm gonna, I don't know where my slideshow went, Dina, so I'm gonna ask you to advance slides, okay?
Oh, that's okay. I just needed to.
Yeah, if you can do that. Oh, I can, all right, let me go back to me. Where's my slideshow? Don't know. Hold on. I'm sorry, just my technical abilities are lacking today. Here we go. Dina,
Yes, Gia.
can you reshare your screen and do the slides? I can't get them back. I don't know where they
I
went.
would love to.
So some of the various doulas, the relationship between doulas and healthcare providers in the past has often been not the best relationship. I think we sometimes, I'm not, you can't see me, but that's okay. I think sometimes it is that doulas aren't, we're not part of the team. We're hired separately and individually by the birthing person and their family. And it's hard, I think, to come into a team environment where people are working together all the time and expect to work together. So some of the things we're trying to do to lead that is to train our doulas on how to be members of a greater care team. They're told about programs keeping silent. They're told about not advocating for their clients vocally. They're told you don't know the medical part of this. You're not you can't make medical recommendations, and that's all very true. But we want to build those relationships, and we want doulas all over the state to, whether or not they're quote unquote community doulas, but all doulas to have access to groups where we can discuss those things, learn more advocacy type of skills, and to how to teach people to advocate for themselves. Slides, Dina. And this is just, we want to bridge that gap because I think as women's health is extremely important to us and to all of you. And as we face more clients with challenges like substance abuse, mental health problems, homelessness, the refugee population coming in, we want our state to be able to show others that we can work together, that doulas are a really necessary part of that patient care team, not just something for people who can afford doulas, not just something for people who know about doulas, as Topaz said, but for everybody. We truly believe that every woman should have a doula. Slide. And this is how we're working to make our doulas part of care teams. We are going to encourage training from reputable organizations followed by certification. Currently in Maine, doulas are not required to be certified or have any formal education to practice. And although we want to allow for that autonomy within the doula community, we really feel like it's in everyone's best interest to get the education and to certify. Most certifications require you to attend births. We want to provide doulas, new doulas starting out and starting their own doula businesses with mentoring from experienced doulas who know how to operate within Maine hospitals or birthing centers, who have connections with doctors and healthcare providers already. We want to provide book clubs, talks, workshops. We have a Facebook page that anyone can join to do just that. And providing education on how to respond to difficult situations without burning bridges. Know when to step in, when to have a conversation with your client about advocacy, and those kinds of things. And those aren't taught in doula training, but we want to have people be able to teach those skills to doulas in Maine. And we want to build provider partnerships and relationships with community programs, because we really feel like it's that's the community that's going to get the word out about doulas. We can advertise, we've been around since 2014 as an organization, and people don't know we exist. And I think for us, the provider community is the community that we need to build a relationship with. Slide. And this is Dina's little saying, it takes a village to raise a child. It also takes a village to support a parent and a family. We see that, I think, over and over again. In the video, Caitlin, and Denise's relationships with their doulas proves that and the relationships we continue to carry with our doulas proves that kind of support is meaningful and provides better outcomes. Slide. And that's our story. And we're happy to come out and to meet with provider organizations, community health organizations, come to doctors' offices and do presentations for your staff and build those relationships, and to let you know that we're a resource who's here to help you help birthing people in Maine. Thank you.
Wow, that was great information. We're going to go to a break, but I did want to point out two questions.
Okay.
There was one in the Q&A where Amanda asked, and she apologized if she missed it, but she asked more if doulas handle any screening for domestic violence, if there's any way you do that at all. And then another person was asking if this service was available to people who had their children separated from them due to CPS involvement.
Yep. We do the first part of that. We do not do any specific domestic abuse or violence screening. However, we're meeting with those people at a very personal level, and that's one of the things we want to train our doulas to recognize signs, and to then, because we have a relationship with maybe that person's healthcare provider or healthcare providers in the community, to be able to say, hey, this person might need some help. We have, because we're there to serve them, we have some boundaries, and we're not trained in mental health counseling at all. So, and we don't want that cross training. We want to be that person who knows that they can support. We see a lot of people in those situations.
I'd also like to add in that we also may be one of the first people to notice if somebody is developing postpartum depression, or something more than the baby blues, and be able to direct them to where they need to go to get help.
Yeah. And what was the second question? I'm sorry. Oh, about
Child protective
Dina specifically in loss training for doulas. There is definitely a component of those who are have CPS intervention, where they're going to the hospital and having a baby, and they know they're not bringing that baby home, because of substance issues and those things. You saw Caitlin in the video, and we are allowed to share. We've talked with her extensively that she has 2 other children that she never got to bring home because of her substance use issues. And this was her, out of 3 babies, this is the one she got to bring home. And a lot of that had to do with getting her involved with Sunshine, getting her involved and going to meetings, and making, and serving both her and the baby in that way.
Giving her that extra support. That's wonderful.
Yeah, that extra support that comes to her house. She was living in a shelter. We can go into the shelter and sit with them and provide that support.
Amazing. Thank you both so much. That was really wonderful. And we're going to break now. We'll come back at 2:30. Thank you so much.
Thanks.
Good afternoon, everyone. My name is Amy Belisle, and I'm a pediatrician and the Chief Child Health Officer at the Department of Health and Human Services. On behalf of the DHHS Commissioner, Jeanne Lambrou, I want to thank you very much for joining us today for the Nurture Me conference. I also want to thank the team at the Maine CDC, AdCare, and all the speakers for their work on this wonderful conference. It is nice to see you all virtually today. I'm impressed by all the work you are doing to improve the lives of children, families, and communities, and hope that you will be able to connect with the work happening at the Perinatal Quality Collaborative for Maine. The goal of this work is to achieve healthy pregnancies and the best possible maternal and birth outcomes in all areas of the state. As many of you are aware, several perinatal initiatives have been launched over the last 6 years with your help, and there is still so much more work to do. Currently, over $10 million in federal funding has been awarded to the state of Maine and its partners over the next 5 years to improve the perinatal system of care and provide support for pregnant people, new parents, and infants. These 6 grants awarded to the Maine CDC, the Perinatal Quality Collaborative for Maine at the Maine Medical Association Center for Quality Improvement, and Maine Health are doing work around strategic planning and alignment, building more infrastructure around perinatal quality improvement with medical providers, and supporting new programs to increase access to maternity care for rural communities and diverse populations, which will help build a strong, healthy foundation for the next generation of Mainers. Department of Health and Human Services and the Maine CDC have partnered closely with the Perinatal Quality Collaborative for Maine at the Maine Medical Association over the last 6 years. Together, we completed an infant mortality needs assessment, which is a model for the current perinatal needs assessment being done by the Maine CDC with market decisions research with a more defined focus on maternal morbidity and mortality and access to maternity care for rural and diverse communities. We hope the results of these assessments will help further define our programming moving forward. DHHS has also championed healthcare quality improvement efforts with the Perinatal Quality Collaborative for Maine and has done work together on a safe sleep quality improvement program and implementing the Eat, Sleep, Console program to improve care for substance-exposed infants in birth hospitals. In addition, in January 2022, Maine joined a national effort to reduce maternal morbidity and mortality by working with the Alliance for Innovation on Maternal Health Evidence-Based Safety Bundles, or the AIM bundles. This work is being led by the PQC, and currently 20 of the 21 birth hospitals in the state are participating in a project on severe hypertension and pregnancy. Today, we will hear from Ashlee, Crowell-Smith, and Nell Tharpe about another PQC for Maine project, the Universal Naloxone Project, a postpartum toolkit for harm reduction. It is partially funded by MaineCare and the Maine Mom Program to improve care for pregnant people with opioid use disorder. We hope that you will think about how to connect this to your work and help promote harm reduction strategies. I'm delighted to introduce our speakers today. Ashlee Crowell-Smith is the project manager at the Maine Medical Association Center for Quality Improvement team as a project manager focused on maternal child health projects. She earned a BS in criminal justice, a BS in psychology, and an MBA from Thomas College. She's helping to build infrastructure to support perinatal system quality improvement in Maine. Nell Tharpe is a perinatal and women's health consultant for the Perinatal Quality Collaborative for Maine and a faculty and program coordinator at midwifery workshops in East Boothbay, Maine. Nell received her certificate in midwifery from State University of New York and her master's in midwifery from Philadelphia University. Certified nurse midwife since 1986, Nell has been actively involved in women's health as a labor and birth nurse, a nurse midwife, and a midwife educator and author, and a maternal child health consultant in public health. She's currently an adjunct faculty at Rutgers University. want to welcome Ashlee and Nell for all of your work, and thank you for all of your work, and really appreciate sharing your story with us today. Thank you.
Thank Amy for the introduction. I also would like to take a moment and thank Maine CDC and AdCare for the opportunity for us to share about the work that we are doing. We are very happy to be here. So with that, I'll go ahead and share my screen. Should be able to see it now. So I'm going to do an introduction about the Perinatal Quality Collaborative for Maine, also known as the PQC for me, and I will then turn it over to Nell to share about the Universal Postpartum Naloxone Project. So some background about the PQC for me is that it was founded in 2018 with a goal to improve maternal and newborn health in Maine. We finally became a CDC-funded PQC in 2022. So we are in our second year of funding. So we're excited about that. Our mission is to optimize perinatal health outcomes and experiences for all Maine families through collaboration, education, and continuous quality improvement. And we do this through the various projects that we are currently working on, have worked on, or are looking forward to being a part of. Our vision is that all babies, birthing people, and families will have safe, high-quality, equitable, and respectful care within their chosen setting. And then the management, PQC for me, is housed within the Maine Medical Association Center for Quality Improvement. Some background, we are similar in structure to those that are functioning as a nonprofit PQC. MMA-CQI is a nonprofit. We are different than other PQC states as they are housed within large university systems or the health departments. So we function in correlation and align with other nonprofit PQCs. We rely on funding from grants and contracts to support our projects, and we also rely on many volunteer hours. So thank you to all of our folks that are volunteers that work with us and those that support us within the monetary ways of grants and contracts. Some previous initiatives that Amy did mention were the Eat, Sleep, Consult project, as well as Safe Sleep. Some current projects that we are working on that Amy did mention were the AIM, or Alliance for Innovation on Maternal Health, Maternal Hypertension Project. We are currently working with 20 of our 21 birthing hospitals, so we are almost at 100% participation, and our focus is to improve the time to treatment rate from the first onset of severe hypertension reading, and that the hopeful outcome is that we will reduce any bad outcomes in the long run. We also have MMRC, or also known as the Maternal Mortality Review Committee, which I'll get in more into, our RMOMS, SMHI, ECCS. I'm throwing all these acronyms at you, but I promise in just a few moments we'll get into further details. One thing that we have currently worked on that we offered to our birthing hospitals that were participants of the AIM work was the A1 post-birth warning signs education. Through A1, we purchased that, and it was offered to them for free. And this is what the post-birth warning signs education is, the poster that can be given to moms upon discharge. So this is something that we worked on as well within focus groups that it stuck out as something that many people decided that it was important to have upon discharge. A little bit more about our structure. This is the Perinatal Quality Collaborative for Maine team. Amy Carter, who is the director of MMA-CQI, is part of this. Myself, Mariah Pfeiffer, who is also a project manager with MMA-CQI, Fuller Hopper, who is an epidemiologist with Maine CDC, Elizabeth Winnebauer, who is our PQC for me evaluator, Dr. Alan Piparillo, who is a clinical consultant, Dr. Brina Holmes, also a clinical consultant, Dr. Anne-Marie Van Hengel, again, a clinical consultant, and then also Deb Dietrich, who is leading our DEIB work group. Additionally, new to this year, we have an executive committee. Dr. Anne-Marie Van Hengel and Mark Minkler who leads the children's program of EMS, are our co-leads. We then have Marianne Heracol as our maternal child health director, Dr. Picarillo as our actively practicing clinician, Dr. Amy Belisle as our state policy representative, Sarah Austin as our perinatal nurse educator, and we are still looking to fill the role of lived experience representative. And lastly, we also do have a membership that consists of 65 plus members, give or take. We have nurses, doulas, midwives, executive directors, doctors, educators, and more. And of those, they represent the following groups of Maine hospitals, community-based organizations, Maine CDC, DHS, Maine Hospital Association, Maine Children's Trust, and many more. And we appreciate all of our members. And we are hoping this year to expand our membership, so be on the lookout for any information on how you could join in the near future. We do have some other initiatives and goals and objectives. Like I said, we have the Maternal Mortality Review Committee, which is focused on expanding Maine's capacity to review maternal deaths as part of the existing maternal fetal and infant mortality review panel. Our goal is to be more accurate and timely. We also have our State Maternal Health Innovations Grant, which is partnered with Maine DHHS, and it's they have a maternal health task force. And on the next slide, I will share what that is and how you can join. We do partner with Maine Health for the Rural Maternity Obstetrics and Management Strategies, specifically to CQI. We lead a maternal mental health echo in partnership with them that is held monthly, and we are currently, next week will be our 4th session. We do work with Maine DHS for the Early Childhood Comprehensive System, specifically around care coordination modules, and that is ongoing. We have our DEIB work group, which is part of our PQC for Me structure, and our hope is that they can address any challenges, share resources, etc., around diversity, equity, inclusion, and belonging. We partner with the Maine Maternal Opioid Misuse Model, which improves care for pregnant and postpartum people with opioid use disorders and their infants by integrating maternal and substance use treatment programs. In partnership, we do have a echo series for that as well. And then we do also have the Universal Postpartum Naloxone, which Nell will be sharing about very shortly. This is the Maternal Health Task Force. It's creating a 4-year strategic plan to eliminate inequities while improving pregnancy and birth outcomes for all of Maine families. There is a QR code here, and then within the resources, we will be able to share a link as well. We do finally have a website that launched in spring of last year. So if you would like to learn more about any of our projects, we do have reports. Most recently, I can speak to that we did a roadmap project that created a wonderful report across the state, and does have some findings and recommendations in there as well within the perinatal space. So highly recommend looking at that. But this is a great use of information that really shows what we have been working on, what we're currently working on, and hope to work on. If you have any questions, please feel free to reach out to me. Happy to answer any and all. And at this time, I will turn it over to Nell specifically so that she can discuss the naloxone work. Take it away now.
All right. Thank you so much. I appreciate it. Welcome to everybody who is in the audience. It's really exciting to be able to talk about the Universal Naloxone project. As the PQC started, we did the Eat, Sleep, and Console and the Safe Sleep, which were both newborn-related projects. And both Dr. Nalibov and I and our maternal team were eager to have a maternal project. And one of the things that we found was that there were no ready-made projects that fit for us. So we designed this project. So next slide, please, Ashlee. So as we go through this, hopefully everybody's going to gain understanding in the value of naloxone distribution to people on birthing units. And our overall goal was to reduce postpartum overdose mortality, but we like to think of the whole family and the community within which the family lives. We also noticed that providers and staff sometimes have their own biases, and we wanted to work to reduce harm from implicit bias. And implicit bias, regardless of whether it's about substance use, whether it's about family of origin, whether it's about economic status, we want to reduce harm from implicit biases. And then we also wanted to increase engagement between hospitals and community health agencies that provide provide harm reduction work for families with substance use disorder. And one of the issues there is that there seemed to be this big gap. There's community agencies and there's hospitals, and the two were not speaking together. And that was a big piece of where we wanted to fill that gap. So next slide, please. So the project was supported by a number of different grants. We're going to talk specifically about the pilot, and then at the end, I'll tell you more about what's happening now that the pilot has been completed. But the original project was supported by discretionary grants from Maine Health Access Foundation, Bingham Program, State of Maine, staff support from the Maine Medical Association Center for Quality Improvement, and in-kind contributions from the Franklin Community Health Network, Healthy Community Coalition. And the pilot was really instrumental in having the robust program that we have now. Next slide, please. So before we get started about the program, we want to talk about why we decided to go with postpartum universal approach. And you can see that from 25 to 44, which are the childbearing years, this is where there's the highest rate of drug overdose deaths. And this is in all people, so both all genders and this age range. But this is the group that we're aiming to reach out to the most. Next slide, please. So we want to get more Narcan out into the community. There's very little risk of harm if it's used on someone who is not overdosing. Of course, we don't recommend using it unless somebody is having respiratory distress from an overdose. So not just if someone thinks they are overdosing, but if they truly are not able to breathe. It will only affect individuals with opioids in their systems, and this includes adults, children, as well as pets, because anybody can get into opioid medications inadvertently. So we want to make sure we know who can use it. There is no risk of abuse. That's a really important piece. There is no risk of physical dependency, and there are no neurological or psychological effects or euphoria. So if someone were to see someone on the street who had collapsed and they were not breathing, and you didn't know if they were having a heart attack or whether they were having an overdose, it would still be safe to use the naloxone while you are reaching out to the emergency medical services. Next slide, please. The other reason we thought it was so important to do a universal approach for this project so that we got as many families as possible is that fatal drug overdoses are becoming more and more common in children age 1 through 18. So it has risen since 2000 up to 7% now of all child deaths. And so we want to understand how we can address this poisoning. And so even though it's an overdose, it is in fact also a poisoning, particularly when a child gets into a medication not knowing what it is. Next slide. As we worked on the project and completed the pilot, Dr. Nalibov and I did write a paper for it for the Journal of Addiction Medicine, describing it. It has received quite a bit of attention, and we've heard from a number of different states, and people are starting to branch out to do this in states like Colorado, Tennessee, Ohio, New Hampshire, North Carolina. I think that's Those are the ones that I can remember right now. So it's been a successful project. And next slide, please. So the project itself has 3 aims. One is to reduce postpartum mortality due to opioid overdose. That will be very hard to show because our postpartum mortality rate is quite low in the state, for which we're all very grateful. However, a high percentage of those deaths are related to, not necessarily caused by, but have an association with opioids. We also want to reduce implicit bias by birthing unit healthcare professionals. So whether it's nursing staff, whether it's midwives or physicians, we want all of our families to be well supported. And then, of course, we want to foster and build relationships between local community harm reduction resource providers and hospital staff, so that if the hospital has questions, they know who in the community to reach out to, and we can have some warm handoffs when needed. Next slide, please. So we developed an educational curriculum that was going to be completed by the prenatal office staff, the providers, and the hospital birthing unit nursing staff. So this is a hospital-based project. And then the curriculum includes an intro to the project, just telling basically what it is and what our goal is, specific modules on identifying implicit bias and applying harm reduction principles in practice, and then a tutorial for nursing staff about how to teach about overdose recognition and naloxone administration. So how to broach these topics with families. It was very important that we included the prenatal office staff. We did not want anyone to get surprised by this when they've come in to have a baby. We want them to know about the project and to be anticipating this education and receiving the take-home first aid kit with naloxone. Next slide, please. So the nursing staff educates the postpartum person about overdose recognition and how to give the naloxone in the community. And then every postpartum person is provided a naloxone-containing first aid kit before they go home. Now, just like with any other medication or recommended medical care, people have the option of declining. So we did have some people who declined the kit, some people who declined the naloxone, some people who declined both of them. But the goal was that everybody got that education about overdose recognition and how and why to use naloxone. Next slide, please. Our guiding principle was harm reduction. We want to reduce harm to people, all of the people having all of the babies, all of the time. So we want to focus on positive change. And this means working with people without judgment, coercion, discrimination, or requiring that they stop using drugs as a precondition of support. We intentionally did not want to focus on people specifically with substance use disorders. We never know who will need extra support. We don't know whose family member might need the naloxone. We are trying to create a situation where we have positive circumstances for families, and families have the support that they need. Harm reduction, when it's applied to substance use, can refer to all kinds of different aspects of it, policies and programs, but our particular focus is on practices that can minimize health, social, and legal impacts for people. And so we wanted to give people the information to know what they could do and how to keep themselves and their family and their community as healthy as possible. Next slide, please. So the other reason that we chose to do this universally or include every postpartum person is that we don't ever know who might need naloxone. So in Maine, in the first 5 months of 2022, almost 25% of people who survived a reported overdose were given naloxone by a community member. There was a study out of Massachusetts looking at postpartum overdose specifically, and they found that fully half of the people who had an overdose had never previously been identified as having a substance use disorder. And so we have to recognize that postpartum is a uniquely challenging time for families. There's so many transitions and so many changes, and we want to provide support for people. So by giving universal distribution of naloxone, we increase the saturation in the community. It decreases stigma and it normalizes naloxone as part of a family first aid kit. And I will encourage everybody to keep naloxone as part of their family first aid kit. We just don't ever know when we will need it. And we also, by doing this universally, we can decrease implicit bias and increase acceptance of all birthing people because we're starting to have these conversations. And one of the things that happens is that by having conversations about recognizing overdose, we can start to understand that all kinds of people can have substance use disorders, and it's not limited to any particular type of person in our community. Next slide, please. So this is what the kit looks like. They may look different at different hospitals, but this was our pilot kit with the Healthy Community Coalition. So it had the bag that everything went in, had instructions for how to use the naloxone laws, a CPR face mask, because sometimes people have stopped breathing. It's why you're giving the naloxone, and you need to perform at least rescue breathing, if not full CPR. Band-aids, poison control magnet, and a digital thermometer. And the families loved having a digital thermometer for their newborn. The community agencies also can put in information about the harm reduction resources in their community. And we did end up adding a suicide prevention magnet. We had someone who went to the emergency room postpartum. They did not have an overdose. They did not need the naloxone, but they did say that because they had received this kit and realized that they could reduce harm to themselves by going to the emergency room when they were in crisis. And so this was a mental health crisis. And we all know that mental health can be a contributing factor to substance use. So that has been a valuable addition. Next slide, please. So as a result of the project and our pilot work and all the feedback we got from all of our team members, we developed this formal project toolkit. And this is available on the PQC website. And it's a guide so that hospitals don't have to be part of our project. They can actually initiate this project on their own because they've got all the tools in this toolkit. Next slide, please. There were a number of requirements for success. First of all, there had to be buy-in within the hospital and strong in-house champions. There had to be public relations, I'm trying to think how to say it, media. So whether it's a letter to the editor, whether it's on social media, whether it was on the local TV, about talking about the project. Because there was a lot of resistance initially, both in the hospital and in the community, until people understood what the goal was. So that was really important. There has to be a stable supply of naloxone. And fortunately, Maine has naloxone that is at no cost to people in Maine. And that has really been an integral part of this project. And then the preparation by the office staff at prenatal visits was so important, so people were not surprised. And interestingly, we did find that there was a generational difference. So younger clients, younger office staff, younger hospital employees were much more supportive of the project than older individuals. And the older individuals took a lot more convincing. And we have monthly meetings to provide ongoing support, problem solving, and feedback, which really help both the hospital providing this project, making it happen, and us developing this project so that it can be replicated in other locations. Next slide, please. So when we look at the first year of this project at Franklin Memorial, we see that almost 100% of people got their harm reduction education. Easy to miss someone now and again, but 97% or 192 out of 197 received their harm reduction education. Next slide. And on this slide, you can see that not everybody wanted the naloxone. So the red line is the number of people who accepted the first aid kit, and most people love that thermometer and were very happy to take the first aid kit, but not everybody wanted the naloxone. And a note about these totals, they're 94 and 76%, but these were based on the total number of births. So not it's out of 186 out of 197, and not everybody got the education. So the numbers actually would bump up just slightly. So really, I was impressed by all of the clients who said, we really want to have naloxone as part of a family first aid kit. Next slide, please. So the pilot ended in April of 2022, and Franklin Memorial opted to continue doing this, and they have good results continuing. We don't collect data from them anymore, but they do keep us apprised of how it's going. The project has expanded now to 2 other Maine hospitals within the PQC. So we are supporting them to do the project, but there are a number of other hospitals who have decided to do it independently. So there's actually a higher number that are doing it, but only 2 within the PQC. As I said, we have the suicide prevention resources in the kit, and we realized that we didn't have a mechanism for the people receiving the kits to give us feedback. And, as you know, hearing from the families who are living this is really an integral part of any great quality improvement project. So we developed a postpartum participant survey that has a QR code that they can scan while they're at their postpartum visit to let us know what they thought of the project, whether they used the naloxone, and any other comments that they might give. We have not received a lot of those back because it was a relatively recent deployment, but so far all of them have been very positive. Next slide. Okay. And I'm happy to take questions, and I see there's a number of comments. I have not been looking at the chat while I was talking.
There are also quite a few comments in the Q&A. Can you see that? Or
yeah, hang on a second. Let me pull it up there.
Great.
All right. So the top one, can you say more about the implicit bias you are attempting to address? And specifically, we're talking about implicit bias for people who have negative reactions to people who use substances. However, when we talk about implicit bias, it could be people have negative reactions about whether it's using substances, whether somebody is LGBTQ, whether they are a person of color, whether they are a person of limited financial resources, whether they have an accent and are from away, whether it's somewhere else in the US or somewhere else in the world. So implicit bias is that internal bias that individuals have. And we want people to recognize it within themselves and then strive to think of a good way to say this, become more open-minded and accepting. So yeah, that's all I'm going to say about that right this moment. And so do providers need to use their own insurance to get naloxone from a pharmacy to have on hand at the office in case of an emergency? I don't know the answer to that question, Andrea. There are naloxone distribution sites around the state where the naloxone is free, and I would assume that providers are able to access that to have it within the office for an emergency. And the current hospitals that are taking part in this project are Lincoln Health Miles Campus and Reddington Fairview. And then we're just getting ready to add Central Maine Medical Center. So, and Laura, it's a great question. Having worked with public health nursing as a consultant previously, I would love to see something like this be part of public health nursing. I will say that in order for this project to go forward, we did have to do some negotiation with the Board of Nursing because nurses cannot distribute medication on their own recognizance. And they did write a committee opinion. It is not easily accessible on their website. So if you have a question, please reach out to me and I will send you a copy of it. Because they did limit it to this project. And I was hoping that the Board of Nursing would have made it for nurses as part of any formal substance use harm reduction project. But that was not how the wording was. So that would require follow-up with the Board of Nursing. And there are, Maine access points can mail kits to the moms. So that would be another way of partnering with Maine access points and see if that would help. All right.
In the chat, we had someone ask about the shelf life of naloxone.
So that's a great question. And we have talked about that a number of times. So every box contains 2 doses. You're often going to use both doses if you are doing an overdose reversal because it binds with the naloxone and it may not bind with all of it. And so a second dose is often needed while you're waiting for the emergency services to arrive. Each box has an expiration date on it. And what we have been told is that obviously we're not going to recommend people use it past the expiration date, but it can often be exchanged through a community resource. So if you went to your local harm reduction resource and said, my naloxone is about to expire in the next 6 or 8 weeks, can I exchange it? They would be able to give it to someone who may need it sooner and would use it within that time frame. So it's one of those things that it's a challenging issue, especially if you're keeping it in your purse or your car and you don't have an opportunity to use it.
There was another question in the chat asking about if there's any current data on how often naloxone is used during pregnancy. If we have any numbers, I didn't hear that during the presentation.
Yeah, and I have not seen that information, so it's a great question. The goal during pregnancy is for people to be on medication-assisted treatment so that they have a steady state and there's no ups or downs. One of the challenges of using naloxone in pregnancy for an overdose is that, of course, it's going to reverse it for the baby and put the baby into withdrawal as well as the mom. And that's one of the things we want to avoid as much as possible. However, obviously, if somebody's not breathing, it would be needed, but I have not seen data on that. And I see that Risa had said, if you have an expired Narcan, it's not harmful. It could still be better than using it, not at all. And I will say, yes, that's true, but we can't advocate for that in this, that we have to say, as a health professional, I have to say, use it within its expiration date. Any other questions? So I know the folks at Eastern Maine are very interested in this project. If you live I saw some comments about the Bangor area. If you live in the Bangor area, feel free to reach out to Eastern Maine, anybody who's doing the maternity, and tell them that you're interested in hearing more about the program and what can you do to help it be part, get launched up there. So I know they have interest in it. It's a big system, and the bigger the system, the more complex it is for trying to get all the pieces in place to make it go smoothly. Right. I'm looking at some of these other comments, so thank you very much. I appreciate all the interest in this. It is so important, and so important that people understand that Narcan and carrying Narcan and buying Narcan at the pharmacy does not make anyone a bad person, and it doesn't actually even indicate that someone uses substances. And I encourage everyone to get Narcan, whether it's free Narcan or whether you buy it over the counter. The more people who buy it over the counter, the more we're going to hopefully reduce the bias against people who have Narcan. So that's one of our big goals.
Well, that was excellent information. Thank you so much. We'll take a short break, and we'll be starting up again and with our next session. Thank you.
All right. Bye for now.
Thank you.
Good afternoon, everyone. My name is Ellen Blake, and I work for the Maine CDC in substance use prevention, and we're lucky enough to have a hand in helping put this event together today. I have the honor of introducing our final speaker for this day, and I just want to say that I'm really appreciative to everyone who's spoken today and been flexible with us through all the scheduling and fought really hard with their cell phone hotspots and all of the other barriers to be here today and be a part of all of this learning. I know that things that were not ideal in many ways, and we're still here to celebrate knowing this information and making our processes better because of it, and that is wonderful. I am here to introduce our final two speakers, who are from the WIC office in Southern Portland. So I will go ahead and do that now. Ahiri Lillian Vitale, she, her, hers, is the Special Projects Coordinator at the Opportunity Alliance WIC Clinic, which is busy and diverse. Lillian strives to be attentive, efficient, and compassionate when interacting with families, and has extensive social service experience from more than 12 years working in South Sudan Human Rights Commission, the United Nations World Health Organization, and with the German Development Service, who is an implementing agency, for UNHCR as a community development officer. Lillian lived and studied in Uganda during the Sudan Civil War as a refugee until she obtained her bachelor's degree in social science in 2006 from Makerere University, Kampala, Uganda. Lillian won an award for academic excellence and was a role model for girl-child education promotion in refugee camps in Uganda. Lillian completed her master's degree in development and emergency practice in 2010 from Oxford Brookes University in the United Kingdom. She moved to the United States in 2012 and lives with her 4 children and husband in South Portland, Maine. Lillian loves to connect with people, volunteer in her neighborhood, and is passionate about education. Our second speaker today is Anna Bullitt. Born and raised in Maine, Anna Bullitt is hers is a licensed registered dietitian. She attended Johnson & Wales University in Providence, Rhode Island, and completed her graduate degree in the University of Maine at Orono. Her 20-year career has included corporate and nonprofit roles in food, health, nutrition, and social service sectors. Bullitt is a program director at the Opportunity Alliance in Cumberland County, where she has worked since 2017. She administers multiple state government contracts that provide resources to improve health and nutrition status among people impacted by trauma, oppression, and food insecurity that are associated with class exploitation, climate and political migration, and generational poverty. Bullitt lives with her spouse and 2 young children in Portland, Maine. Thank you both for being here today.
Thank you for having us. We're so happy to be here, and we are especially appreciative for everyone who's stuck around. We know it's really hard to be the last speakers of the day. We know some school districts didn't even have school today, even though the sun is like blaring out my window. So thank you everybody for taking the time to listen to our humble opinions from our little corner of Maine. So just to start, we have no disclosures, and we want to ground everyone who's here today in some of the sort of truths that we hold to be self-evident in our WIC program. And those are the following. We truly believe that parenthood is a human right and that it ensures our collective future. This is especially true in Maine, which is the oldest state in the nation. So we are very humbled to parents who are raising children here because we need those children to ensure that our state has a population. We also believe that poverty is not a policy failure. We believe that poverty is a policy failure, not an individual failure. And that's really important when we work with folks who are experiencing poverty, that we make sure that they know it's not their fault. Also, we believe there's just no scarcity of resources, just the inequitable distribution of those resources. And we truly believe that diversity enriches us all. So we look forward to sharing with you our presentation.
Hello and good afternoon, everybody. My name is Ihiri Lilian Vitali, and I'm the Special Project Coordinator for the Opportunity Alliance WIC program. Anna and I have worked for the last 7 years together, serving the incredible population of WIC families. And we love seeing these wonderful children and their parents come to our clinic. So today, in our presentation, we'll be addressing 3 objectives. We'll be identifying systemic service, support service, and healthcare access barriers faced by immigrants who are new to the United States. We'll review some of the culturally competent strategies to address systemic barriers to social service and healthcare. Then I will learn about the Opportunity Alliance grant-funded innovation to educate participants, increase benefit redemption, and improve the WIC participants' experience. In our presentation, we'll look at a brief overview of the WIC program, a touch on immigration. We will review systemic access barriers, creating a welcoming WIC. We will talk about our 3 grant-funded projects, namely we have the shopping experience improvement, then the birth empowerment project, and community innovation and outreach project. Then we'll respond to questions and comments at the end of the presentation. So the acronym WIC stands for Women, Infant, and Children Program. WIC is a USDA supplemental nutrition program for pregnant, breastfeeding or chest feeding people, infants, and children up to their 5th birthday. WIC is administered at the federal level by the Food and Nutrition Service. WIC provides money on a card to purchase specific nutritious food and infant formula at WIC-approved grocery stores and farms. These foods are carefully selected by the state agency nutrition coordinator and dietitians to meet federal dietary standards. Families with income on or below 185% of the federal poverty level and are all on main care or TANF or receiving SNAP and are on nutritional risk. To continue receiving WIC benefits, participants must attend appointments, which comes every 3 months or monthly if more documentation is needed. Nationally, WIC staff utilize value-enhanced nutrition assessment, a form of patient-centered care. It systematically collects and evaluates information drawn from the patient, while at the same time allows staff to engage the participant in dialogue about their needs and goals of healthy behavior. Statewide, Maine WIC serves over 18,000 participants, a substantial increase from 16,000 in 2021. That's around an increase of 2,000 participants. And the Opportunity Alliance WIC program alone serves 5,300 unique and diverse participants every year. In Cumberland County, where 24% of all Maine infants are born, the percentage of non-United States-born birth parents is 17%, compared to 9% statewide. You can find that information in the CDC website, that's CDC Wonder, and just look around in that website and you'll find more information. Half of the Opportunity Alliance Week participants are immigrants, most from African nations, with smaller population from Central America and the Middle East, including Afghanistan. There is no single reason why families immigrate. Each person has a reason, and we don't want to tie them to the bitter experience they had. Others even do not want to disclose. Many who make the journey from Africa to Brazil and through the southern border via bus and foot, crossing rivers and jungles, endure violence, including sexual violence, exhaustion, malnutrition, injury, birth, and death on the road. At your own time, please read more in the series, Long Way Home, from the Portland Press Herald. I also happened to watch one of the documentary put on YouTube by one of the YouTuber who purposely traveled from Brazil to United States on foot, and he documented each and every step of his journey with the people he was coming with to the United States. So you can go to his YouTube channel. It's called Dakito 1. That's DARKITO 1. You can see the life experience of what this population experienced when they were walking in the jungles and crossing the rivers. So many of the immigrants who come to Maine have obtained at least a reasonable level of education and advanced degrees. But due to federal laws, asylum seekers are unable to immediately obtain legal work and therefore income. So municipalities may utilize general assistance program, and some, like the Portland Access FEMA and resettlement resources to welcome new to the United States immigrants. We appreciate many local immigrant-led organizations support service access in the Cumberland County area like MARC, MIRC, and Presente, among others. They play a role in these families finding a community, obtaining economic stability, and participate in the system. So I'm not going to teach you a lot about like Africa, but that map is just to give you a picture of how huge Africa is. When we talk of Africa, it's not a country or a size of United States. Africa is a huge continent. It boasts 54 countries and is 3 times larger than the United States. And Congo alone, you can see in the west side of the map, it's the second largest country in Africa with a population of around 102 million people. There are about 75 major languages with over 1 million speakers each, and over 1,000 total ethnic languages spoken in the continent. African nations were brutally colonized throughout history by Britain, France, Germany, Portugal, Spain, and Italy. Exploitation of the African people for the exploitation of their minerals continued up to date. The 400 years of the transatlantic slave trade and overall history of colonization dramatically changed the social structures of economies of many African countries, hence massive rural-urban movement in the African continent. So the exploitative relationships continue today between African nations and the United States, Europe, China, Russia. I would say in the last 5 to 7 years, recently newly arrived African immigrants coming to the Opportunity Alliance Week are largely from the Democratic Republic of Congo and Angola. So I'll yield to Anna.
When we practiced this yesterday, we were sort of scratching our heads going, maybe we need to teach a college course because this is a lot of information that we're trying to put in 45 minutes. So I do want to just acknowledge that we're really glazing the surface of some super heavy graduate level topics here, but we encourage everybody to learn more if it's something that you find interesting. And there's lots of hyperlinks throughout these slides, as you'll notice. So I'm going to move on and talk about the systemic barriers to service access. And when we talk about the systemic barriers that we witness at WIC, we're, of course, for the purposes of this presentation, talking about the barriers that we see immigrants and we work with immigrants navigating. I'll say, though, a lot of these barriers are true for any marginalized community. And obviously, we serve lots of different types of people at the WIC program. So I just want to make sure that that's clear. The number one barrier, I think, that anyone will tell you who's living with in poverty or working poor will tell you that lack of affordable housing. Even a family with some money, a housing voucher, or a job will be really hard pressed in today's economy to secure safe housing within their budget and within a needed distance to their place of employment, not just in Portland, but pretty much in any of Maine's big cities or towns. And the other thing that we want to mention is that not having the home, of course, causes continued trauma. And then not having a mailing address makes accessing services hard because there's no address to write on your applications for services. The other thing we just really want to highlight is the overall lack of trauma-informed care. New to the United States immigrants are processing massive amounts of information and adjusting to new cultural norms just to survive their circumstances on a regular basis. So the impact of chronic and toxic stress on maternal and child health is really well known. Despite that, it's inadequately addressed in our social service and healthcare systems. Black Americans live with systemic racism, daily microaggressions, and government-perpetuated race violence as their norm. They've grown up here, they're familiar generally with the racism that's part of their everyday. This experience is sometimes new for Black immigrants. And it's also actually documented that Black immigrants face an added layer of inequity because of that racism. So they're getting a double whammy. They're Black and they're immigrants. And that is a hyperlink to some really great data about that experience. There's also this lack of central service access point, and that's for lots of reasons. And some states are working hard to address this, and Maine included. We're just not there yet. So services, healthcare, and insurance feel accessible and challenging to navigate. I'd say by anyone. I have a hard time when I'm figuring out my health insurance. So you can imagine for someone experiencing multiple traumas, it's even harder. And of course, the lack of transportation justice, this is statewide. Car ownership remains out of reach for many families who are living within poverty or who are working poor. And our families who are immigrants have spent possibly their life savings on their journey, and then they get here and they also can't earn income. So car ownership, of course, still remains out of reach. And then public transit is really confusing, time intensive, or depending on the city or town that you're in, unavailable completely. Oops. So the other systemic barrier that we're glazing over, but I think is kind of the heart of this presentation, and you'll see this all the way through in every slide, is this lack of cultural humility. And cultural humility is a tenet of trauma-informed care for those that were versed in trauma-informed care. And so there's this great article in a 2018 issue of Global Food Security that reviewed an array of evidence supporting culture as a powerful preserver of emotional and physical stability. So culture includes many aspects of daily life, right? From the design of our communities, social dynamics, the expectations of parents, right? How we expect parents to behave in a waiting room, how we expect them to watch or not watch their children, and of course, food. Immigrants can acclimate better if services operate with this intentional cultural humility, right? So instead of judging the mom that's letting her kid run around my waiting room, If I'm instead curious about that as a custom of expecting maybe the other adults in the room to help take care of this kid, then I'm practicing cultural humility instead of judgment, and that is making it a trauma-informed care space for that little bit. Most people in the United States, we live often unknowingly by values that are deeply rooted in white supremacy. And a lot of us have done pretty minimal work to unlearn those biases and unlearn the continued role that those biases play in system justification. And that's a hyperlink to system justification theory article that I really encourage everyone to read. It's an amazing article. So there's also this lack of culturally relevant foods. And that doesn't mean that there aren't grocery stores that sell a wide array of foods in Maine, but it means that they might not be accessible. So access to familiar foods that are culturally important are known to improve food security, especially during and after traumatic events. And this is where I geek out a little bit as a dietitian. One of the ways that we know this, some of the evidence that's been done around this is not with immigrants at all, actually, but with our troops, with American troops. So deployed American troops, morale is higher and they perform better. Their health outcomes are better, the better the food is. So when foods from home are warm and hot, so I'm talking about instead of eating like a whatever they are, MER, eating a hot meal. So that's why our deployed troops, our military services make setting up cafeterias when we're overseas one of the high priorities. So I just think that's cool, right? So this need of cultural foods crosses all cultures. Imported foods here in Maine might not be covered by benefit programs. They might be cost prohibitive or only sold in stores that are like far away from where a family can get to. And then basics like cooking oil, preferred proteins, and rice might be inaccessible, preventing cooking and consuming of familiar foods that are important for the culture. And this can be particularly challenging for parents of young children. We were recently just on a little trip visiting family. We were just in New York and at my sister-in-law's house. The brand of peanut butter was different. And so my 5-year-old wouldn't eat it. So I just think about that. And then to amplify that by every food being unavailable is a big thing to think about. So last thing I'll say about systemic barriers, or maybe not, I feel like maybe there's 2 more slides about this, sorry, is the technology barriers, right? So social service application, and participation, it's time intensive. Anyone that works with this population knows that. If you've ever tried to fill out a food stamps application, a childcare subsidy application, even if you speak the language, it can be pretty dizzying. And then also, even like the WIC program, it's not administered by one agency, right? It's Maine General, so it's the hospital in Augusta, it's the CAP agency in our area, and then it's Maine Family Planning down east. So it's pretty confusing to someone that's not used to navigating systems. Also, a lot of our programs use use apps like smartphone apps, and so that also can be a barrier, right? Downloading an app requires that you have space on your phone, and we work with parents, right? They have thousands of pictures of their kids on their phone. They might have pictures from back home before they came to the United States. So to free up space to download an app itself can be a barrier. And then, of course, families experiencing homelessness have this added level, right? Like not having places to charge devices consistently. Maybe they need to share the smart device with multiple family members. There might be a teenager in school who needs it to do homework. So these are all pretty big barriers. And then also, this is one we experience, right? Those who administer social service programs might themselves not be technologically savvy, right? Or have experience communicating via interpreters or using WhatsApp. And so there's multiple layers here. There's the participant side, and then there's also the staff side of, we spend a lot of time helping our team members get comfortable texting in other languages and doing things on their smartphones that maybe they've just never done in their personal life. So how do we do this? Well, it's not one, there's no one right way to do it. And I think the underlying most important thing is this cultural humility that I talked about earlier. And we're just really committed to being aware that the American way of life is just but one of many healthy and safe ways to live, right? So if there's something, we might look it up on the World Health Organization. We might Google parent customs in other places, because it's just really important to have this understanding that there's lots of different okay ways to live. And this idea that the American way is the best way is silly. We also try to really remember that words, concepts, and phrase translation is complex. I have to give tons of kudos to our Maine Families colleagues at the Opportunity Alliance who are doing this super cool project I hope you all get to hear about, and specifically around this idea of translating concepts around parenthood and around early childhood development. So also some languages like Spanish literally take more time, right? To say the same concept in Spanish takes 25% more time to say than English. So we just need to build in that time for cross-cultural interactions. And that's not something that we're used to, right? We're bam, bam, bam. We have busy schedules. Healthcare workers are, 15 minutes with a patient. So when you think about how to make a trauma-informed space, how to make a culturally humility-focused space, it's time, it's staffing. Also, little things like knowing which languages are spoken in which countries and remembering that information helps make participants feel valued, right? As we started seeing more families from Afghanistan over the past couple of years, it's important that we know what languages are spoken there, whether it's Dari or Farsi. There's different languages, and so it's important not to assume. And then trauma-informed spaces. I'm sure a lot of you know about this, right? Calming spaces. We don't have a TV blaring in our waiting room because that would just be too triggering for some people. And then the phrasing of our intake questions. So standardized questionnaires themselves are often not trauma-informed, right? Or not considering the population that you're serving. Lillian talked about sort of the really dangerous and harrowing journeys that some of our families have been on. And so it's important that we don't assume anything about who is here with them, right? And so we might say, what are the names and ages of the children under age 5 who are with you now? Because they might have had to leave some children in another country. We might say, do you know if you might be pregnant? Because they might not know, right? They might be a victim of sexual violence. They might not have had a normal period in a long time because of trauma. So there's lots of ways that we can see the question on the screen that we have to ask and we have to answer to be able to enroll someone in our program. But there's ways we can phrase it so that it is appropriate and trauma informed. Basically, we just encourage everyone to approach everything with curiosity. We like to say, don't yuck my yum, right? Whether it's food or otherwise. We're like, this a good example of this is this, like it's bad to like cook fish in the microwave in an office. Someone even said the other day, like, sorry, I'm the one warming up fish. And it was our team at the table in the office kitchen. And we were like, we're the last people that are going to judge you for warming up fish in the microwave. Like, come on, we want to hear it all. We want to smell it all. And so this is just one way to do that. So we really believe that frequent trainings on, bias, anti-racism, trauma-informed care, and health inequity are necessary. But we would probably, I think everyone on our team would probably tell you that the most powerful driver for us in our experience in improving our cultural humility has been fostering this diverse, multilingual, multidisciplinary team that we are really honored to be part of. And this is that team. There's one person missing. Don't tell her. It's Pauline. She'll be mad that her picture's not here. But we could give an entire, presentation on the intricacies of creating and supporting an equitable, diverse, multilingual team, especially in a historically white organization with all white leadership in a white state. It requires commitment on multiple levels. And like I said, this presentation today could be many presentations. But for the sake of time, we will move on.
Okay. Okay, so to address these barriers, we must find ways to really make sure we address them well. So our program seeks and uses grants to overcome equity gaps in program funding, to improve cultural competency and provide resources to address social determinants of health for weak families. And a more recent federal grant awarded for our shopping experience improvement project is funded through 2026. So I will say thanks to Ginger Roberts-Scott, that's our main WIC CDC director, who worked tirelessly to secure the funding. And Food and Nutrition Service utilized money from the American Rescue Plan for shopping experience improvement projects. grants for states with the goal of improved benefit redemption, especially among historically underserved communities. So in collaboration with the Opportunity Alliance Week, Maine Week sought and received the SEI grants to fund community health workers in 3 public health districts with the largest immigrant population. So it's the Western Maine, Cumberland County, and York County. This made it possible for WIC to hire multilingual community health workers in early 2023. Now they play a greater role, not only in improving shopping experience, but covering a wider demand. So our community health workers coach WIC participants on achieving independence in navigating food procurement in Western-style grocery stores, and specifically how to effectively redeem WIC benefits. So WIC counselors check eWIC, that's the WIC card that our participants use, and they check the transaction history to identify participants who need shopping, education, and make referrals to the community health workers. And the community health workers educate participants on WIC shopper application, approved stores and food brands that they can purchase, concepts like benefits expiration, provide cultural brokering and interpretation in WIC clinics, and host farmers market trips to these families. So at the Opportunity Alliance Week, they transport new participants to stores and show them how to shop up to 3 times. They teach participants how to use public transportation. Of course, this is not without challenges. And the community case workers also have a caseload. It's not limited to immigrants only. They have helped English-speaking participants who are experiencing postpartum anxiety and other difficult moments in life. Since the community health workers started, WIC benefits redemption has increased drastically. We received a lot of comments from stores associates who say transactions are made easy for them because of the community health workers assisting these families during checkouts. Since the community health workers are from the communities, they build rapport and these participants, they also provide valuable feedback to clinical staff and leadership about living conditions and experiences of WIC families. Participants are grateful that the community health workers can interact with them in the languages they speak, because our community health workers speak English, French, Lingala, Portuguese, Kinyarwanda. They also hold advanced degrees and can understand dynamics of life and act as WIC ambassadors in the community.
I'm going to talk just briefly about another grant that we had, and we've completed this project, but not everyone maybe knows about this, and so we'll talk about it just briefly. In 2020, Lillian and I wrote a grant from MHAF, the Maine Health Access Foundation, to try to make some videos, some patient education videos, and so we originally were going to hold focus groups, but then there was this like big pandemic. So what ended up happening was that Lillian did a bunch of interviews with birthing parents from the African immigrant community who are WIC participants. And then using the information that she gathered from those interviews, we identified topics to make videos about. So those topics that we ended up covering, they include just OB/GYN healthcare basics, health insurance, reproductive rights, some basic videos about WIC and what the program is, and then breastfeeding. And a really big important one for us and for a lot of our provider partners was making a video about proper infant formula mixing. This is a pretty common issue that we teach about a lot, and I know our provider partners teach about it a lot too. So if you haven't checked out these videos, that is a link. I encourage you to check them out, and they're easy to text to to your patients. They are in English, French, Lingala, and Portuguese, and all of them have English subtitles. So if someone is an English only speaking provider, but wants to show it to someone they're working with in Lingala, then they know what's happening in the video as well, which is pretty cool. The videos so far have we uploaded them in probably 2022, and they have between 50 to 200 views, depending on the language and the video. We definitely need more avenues for sharing in the community. They're hosted on the TOA's YouTube channel. It's pretty easy, like I said, to share the links. They feature real WIC families, which was lovely. They feature real WIC staff, and then our partners at Greater Portland Health. And there's a little background behind the scenes photo from one of our filming days. We partnered with two different video media companies, Knack Factory and Lene Media here in Portland. We really prioritized hiring Black-owned businesses, and this is something to think about. If you do have grants and you are working with a marginalized, with a specific community, one of the things we were really cognizant about was spending the money from that grant within the community that we were seeking to serve. And so our catering, our hair and makeup, our voice actors, we made sure to hire Black-owned businesses for that stuff. And then we also provided stipends to the non-TOA staff who acted in the films. The lessons we learned, just a few of we learned many lessons, but a few of them, the shorter the video, the better. And moving forward to put money in grants for third-party marketing, data collection, and evaluation, which you will hear about more as we talk about our next grant.
Okay, so our next grant is the WIC Community Innovation and Outreach Project. Our largest grant to date, which was like $706,000 in federal funds through the Food Research and Action Center. And this is an 18-month project. So our phase one of the project kicked off with hiring 2 full-time multilingual WIC nutrition counselors and 1 project coordinator at Maine Medical Center to provide on-site WIC appointments with priority to new enrolling WIC eligible families, pregnant people, infants, and patients with extreme hardship making it to our WIC offices for appointments. So the goal is to lessen burden of WIC participants among immigrants, WIC eligible families, and increase participation. You can imagine if you have 2 separate appointments, you have a pediatric appointment or OBGYN appointment, and yet you also have another appointment in WIC. So this project makes it easy for these families to be seen at the same facility. So the Opportunity Alliance staff access EPIC. So we obtain demographic, that's the weight, height, and blood iron data, which are measurements normally taken at WIC appointments. They manually data enter in Spirit, which is a Maine WIC medical information management and benefit issuance software. This shortens the time participants spend in WIC appointments. We realize at the present that no data flow between EPIC and Spirit. So that's the software system for the WIC program. And we hope that it could be a future goal with some additional funding, if that's possible. So the Opportunity Alliance WIC staff at the hospital access pediatric and OBGYN clinic schedules, cross-reference Spirit, identify priorities patient for WIC team, and write notes in EPIC informing care team to hand off the patient upon medical visits. And that's the communication we always have with the team, the PSR, the nurses, and the doctors or the primary care physicians. So participants may still visit the WIC office after their appointment at the hospital. So the hospital-based WIC intend to enroll pregnant people in WIC earlier in their pregnancy, a metric tied to improve health outcomes. and keep participants who frequently missed appointments active with benefits. So in our phase 2, with assistance from our Maine Immigrant Rights Coalition, the Opportunity Alliance will gather data from focus groups of African immigrants with eligible caregivers. The goal of this focus group discussion is to identify those health and nutrition education topic areas immigrant parents and caregivers would like to learn more about when accessing these services, and identify subject areas frequently covered by WIC counselors that need improved cultural and linguistic interpretation. I remember Anna mentioned this. For instance, let me say the blood iron. How do you interpret that? The division of responsibility or parental duties, satiety cues, and many more. So then we'll come up or identify the best modalities for such education. So like having printed materials, have classes, videos, or individual counseling programs. So WIC entrusts MARC, that's MIRC, as an independent agency that will host and facilitate focus groups to ensure participants do not feel that WIC staff are influencing or judging. Technical support and evaluation comes from the John Snow Incorporated. That's the JSI. People who participate in the focus group discussion will be provided with meal and childcare during the sessions, along with stipends.
I am watching the clock, so know that we only have 2 more slides. And I just want to, this is an important one, so I do want to mention a couple of the things on here. So we couldn't be doing this program at the hospital without the Access to Care team, specifically the Access Care Director, Kim, at Maine Health. They're our main partner within the hospital. They provide leadership and understanding of system navigation. You can imagine that, to bring on staff at the hospital, they're treated like contractors, but this has involved departments, far, not just the clinic, right? So legal department, IT department, security, human resources, risk management, basically all the departments we've had to navigate. And so Maine Health's Access to Care team has really helped us with this. The other thing is we wouldn't have even thought of this project if probably by ourselves, if it wasn't for Steve DiGiovanni and his, leadership and support and really welcoming these creative solutions. So this little dream team also couldn't happen without Deborah, who's the longtime pediatric clinic practice manager. And so I just want to point out that like doing a project like this that's novel really, really matters about the relationships and having lots of champions from different departments. Because also the social workers play a huge role. They're advocates within the hospital and our friends, right? So it's good to have friends in every place because then you can access and do what you're trying to do. We also hired a couple previous Maine Health employees, and that was really critical because this timeline is tight for this project, and that made onboarding, epic training, it made it easier and faster and achievable within this time frame. So the first appointment started in November, and it's been off to the races since then. I think the current caseload is about 150 patients that are being seen by the TOA WIC team at the hospital. And what we've done is we've designated with the state WIC support, it's a designated clinic number in our software system. So that allows for separate data collection, which then can be compared to our overall caseload, which is really cool. And so we really look forward to sharing more outcomes about this project and with our community next fall. A couple final thoughts and questions. We just want to say, we are happy to have the opportunity to write and receive grants to improve our participants' access and use of resources. But of course, one wish we always have is that federal funding and program policies adequately met the needs of staff and participants, from all walks of life, and so that we didn't necessarily have to go after these grants. It is an honor to be part of families' lives during pregnancy and support them in this really vulnerable early years of parenthood. And we can't say enough about that. I know Lillian mentioned it at the beginning, but we are just humbled every day by the families that we serve. So thank you so much for attending, especially at the end of the day. I know we don't have a ton of time, but we are happy to take questions now or receive that communication via email. And I think in your packet, there's a picture of me and Lillian because we were virtual, but this is our kids after we brought them to the ballet. Maybe that's what Gideon's doing. So there's our contact information, and I will open up the chat, I guess, so I can start to see questions. And thank you so much for having us. All right, Lillian, I'm reading a question here. It says, do you have any recommendations for resources and preferred food for people from Angola and the DRC? I have clients who are homesick and really want to find familiar and favorite foods.
Okay, so as Anna mentioned, it doesn't mean that there's no variety of food in the United States or in Maine here. But the issue is how to access this food. And that's why we have our community health workers who can drive these participants to places where they can find these culturally competent food, type of foods. And there are those local stores who import food from Africa and from Southern Africa, from South America. So we don't have a resource that is built to distribute and say, this is where the foods are. But by connecting or referring these families to the community health workers would be able to assist them to take them to where the cultural foods are found.
We do have a colleague named Pauline, who I mentioned earlier, because she's annoyed because her picture's not in the slide. And she does give a presentation on foods of Angola and Congo. And so if you've not had the pleasure of seeing that presentation, we are happy to ask her if she'd give permission to send her slides. So if you want to send us an email, we can check with her, and we would happily ask that of her and have her share them. And feel free to invite her through us to your educational needs. So another question, are there trauma-informed guidelines, tools available that you would recommend for professionals working with non-native English-speaking people that you would refer, include intake phrasing examples, common cultural practices, culturally relevant foods, etc., for different regions? Not that I've seen. I don't know about you, Lillian, but I feel like we've been building the plane as we fly it.
Yeah, we don't have any at the moment. And that's what will be maybe the next project or activity to do, like to come up
postpartum mental health node
to come up with flyers, something like this to distribute or give out to participants who are asking for this information, and maybe give them directions of where they can go and find some of it.
Great. Thank you guys so much. This is great. We are definitely out of time, but I do appreciate your presentation very much. And you all, everybody in the conference, you guys have their contact information, so feel free to reach out to them. And Anna and Lillian, thank you so much for your presentation. So what we're going to do, and I apologize because we're a little short on time, but what we're going to do next is we have a very quick sort of set of announcements from Britt Hanford, who I'm just going to briefly introduce to you all. He is with the U.S. Department of Health and Human Services. He is the regional director for Region 1, which is what we're in. So that's Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. He also serves 10 of our federally recognized tribes. So he's been in this position for just a little over a year. So Everett, congrats on your 1-year anniversary. I'm not going to go through the whole bio, but what I will tell you is that he has served in various positions, one of which being the Deputy State Director for Senator Elizabeth Warren for 3 years. He also has been in her administration for almost 10 years. So he's really worked his way up through the different ranks and building his portfolio. So he also has received his Master's of Business Administration from Public Health Administration from the University of Southwest in Hobbs, New Mexico, and a business certificate from Northeastern University in Boston, as well as a Bachelor of Science in Sports from Johnson and Wales University in Rhode Island. So with that, Everett, I'm going to turn it over to you for a few brief remarks.
Sure. Thank you so much, Marianne, and good afternoon, everyone. As Marianne said, my name is Everett Hanford, and I have the privilege to serve as the Region 1 Director for the U.S. Department of Health and Human Services, which encompasses the 6 New England states and the 10 federally recognized tribes. First and foremost, I just want to say thank you to our partners at the Maine CDC, Dr. Va, Amy Bilal at the Maine Department of Health and Human Services, and of course, AdCare Maine for their resilience and dedication to bringing this critical forum to us and for allowing me to provide greetings and gratitude on behalf of our Health and Human Services Secretary, Javier Becerra, and for prioritizing women's health here in New England. This work truly resonates deeply with us at the White House. Recently, the Biden-Harris administration released their blueprint for addressing the maternal health crises. And the blueprint outlines priorities to improve maternal health and outcomes in the U.S., with one of the priorities being increased access to and coverage of comprehensive, high-quality maternal health services, including behavioral health services. And I know today you've emphasized the importance of incorporating compassion, family engagement, equity, increasing doulas, and expanding culturally competent care. Since the launch of the blueprint, we've seen significant policy changes and increases in funding that improve access to maternal mental health services. One critical action the administration has taken to move this needle was implementing the state's option to extend Medicaid's postpartum coverage from 2 months to 12 months. This here is a life-saving opportunity made possible by President Biden's American Rescue Plan and was permanently consolidated in the Consolidated Appropriations Act of 2023, which President Biden signed into law earlier last year. And I'm proud to report that 39 states, including all 6 New England states, and yes, that includes Maine, have made this annual commitment, which is amazing. Here in Region 1, with events like today and the many that we have across New England, we certainly want to stay connected with all of you. We welcome you to join us virtually on January 24th with the Massachusetts Department of Public Health and the Ellen Story Commission on Postpartum Depression for the first in a series of roundtable discussions on the state of Black maternal health in Massachusetts, which is scheduled to take place on Wednesday, January 24th from 5:30 p.m. to 7. We will implement recommendations at the community level from the Special Commission on Racial Inequities in Maternal Health. And then I also encourage you to join us on Saturday, April 13th for the Maternal Outcomes Matter Showers Tour, or the Moms Tour, which is focused on reducing the high maternal mortality and morbidity rates in the U.S., where we continue to nurture mothers and families. And you can certainly see more information on that from our Twitter page at HHS Region 1. On behalf of the U.S. Department of Health and Human Services, truly I am honored to be here with you all this afternoon. I'm confident that today's shared experiences were both fruitful and inspiring, and certainly encourage you all to continue to be beacons of light and hope in your respective communities. Thank you.
Thank you, Everett. That was great. And if you have a link to what you were just referring to for the couple of opportunities for folks to get involved, I would love to have you put that in the chat and or send it to Lorena, and we can definitely get that out for you to all the folks on the call today. That'd be great. So I'm just going to take a moment, let you guys reflect for a second, take a deep breath, think about all the things we heard today. Amazing presenters. I don't know about you guys, but a couple of our presenters really had me, had the tears flowing a little bit. And I've heard some of those stories before, and they still get me every time. So today has been an amazing experience in getting to hear from lots of different folks and really making some connections between the different presentations. I was very impressed at how well they flowed together. I mean, I knew that they would because we helped plan it that way, but it really seemed to work for us. I do want to throw out a big, giant thank you to the planning teams. There was a lot of people that came together to make this happen. There were even more people to help us flip this from an in-person meeting to a virtual meeting. So I appreciate you all hanging in there and showing up for us today. And with that, I will remind you that there is a link in the chat for an evaluation, and you will also be sent one to your email addresses. Probably about five or so days from now, AdCare will get that out. And please take some time to think through that. We wholeheartedly use those evaluations to plan the next summit, and we do take your thoughts into consideration as we're trying to come up with new topics that we want to share and find some really new and interesting, exciting presenters. So please take some time to do that. Thank you to all of our presenters. Like I said, I know that this was a little bit different than what we planned, but you all did a phenomenal job. And as the Title V director for Maine, I could not have asked for a better planned day. So with that, I am going to let you all go. I hope you all survived this little storm that we had hit us again. And I hope to work with you all in the future. So with that, everybody have a great evening, and we will see you all soon.